When last we met, we were talking about legislative matters, so we'll return to those items on the agenda.
Thank you, Dr. Phillips. I became aware over the lunch break that we have potential public input on the last item we considered, which is the Bloom Bill, AB 2221. There is, I understand, representatives from the OTAC, Occupational Therapy Association of California, that would like to make a few comments, and it seems appropriate since they're here. And Ms. Burns, maybe you can help clarify, as we hear public comment, how it relates to sections of the bill that we've had concerns about, so that we can keep that in focus. And as a reminder for the public comment, we're in the midst of reviewing legislative matters. I'm currently the chair and trying to move these things forward, and we're going back to an item that we finished just before lunch. So this is probably a good point to invite public comment, and it would be here at the table.
Just for purposes of agenda planning, how many people do you expect to have speak? Because we're going to limit your time. If more people that speak, the less time you'll have to speak.
So we have, besides myself, we have 4 practitioners that are here.
Okay, and you would all like to speak?
If possible.
Okay, well, we'll have to limit you to 3 minutes each then. Okay?
Thank you.
Now it's on. Would you like me to go ahead and begin? Thank you. Thank you. So, President Phillips and Board, my name is Ivan Altamura. I work for Capital Advocacy. I represent the Occupational Therapy Association of California as well as the American Occupational Therapy Association. We very much appreciate you giving us a chance to address a bill that you already brought up. Your efficiencies in your agenda caught us off guard. We were anticipating this coming up after lunch, so we very much appreciate the opportunity to revisit this. So I just want to say a little bit about the background of the bill, and then the practitioners that are here today from OTAC would like to share with you some of their practical application of occupational therapy as it relates to mental health, and hopefully address some of the concerns that you've already discussed, and perhaps we could have a dialogue if there are questions afterwards. So as you all know, the Occupational Therapy Practice Act was passed in 2000, and it has not really been substantively updated since then. There's been a few things here and there that have been amended, but for the most part, there has not been any substantive changes. And obviously, since that point in time, we've had the implementation of the ACA, and there have been some changes and some advancements in occupational therapy education and delivery of services. And so OTAC and AOTA really set out, and over the past few years has done a lot of basically just kind of trying to figure out where in all these changes, where do things sit, and what kind of amendments and updating to the Practice Act do we need, and keeping in mind always wanting to stay in our lane and not going out of our scope of practice. And so that's the lens from which we approach this. And so our bill, which you have before you, has been substantially imprinted in the same form, also with the language that you have concerns about, since February. And we did our due diligence in reaching out across the board to a wide range of other professions to see if there were any concerns, feedback, things that we could address. Specifically, I have reached out to the National Alliance of Professional Psychology Providers and the California Psychiatric Association through their representation in Sacramento to seek feedback, and did not get any from the perspective of
the National Association of Psychology Providers?
National Alliance of Professional Psychology Providers.
I don't think any of us are familiar with that organization.
That's who as far as in California, they're represented.
We have the California Psychological Association here, and that is
Missy Johnson. That's who I reached out to, is Missy Johnson.
You may have, as far as psychology is concerned, you may have reached out to the wrong people.
Regardless, I just wanted you to know that from the perspective of the bill being in print, has been in print since February. from the perspective of our role or OT, the history of OT, being born out of the early 20th century when soldiers from World War I were coming back with PTSD, that was really what occupational therapy was born out of, was dealing with these soldiers coming back and how could they cope with their PTSD. And so that's really our roots started in a mental health setting, and so I'm sure you probably know that. I wanted to point out that a couple things that when we were looking to amend our Practice Act, one of the things that we did not change, which remains in the current code, is a specific section that says nothing in this chapter shall be construed as authorizing an occupational therapist to practice psychology. That remains unchanged in our code section, and we are also further addressing it with some amendments that we're going to be taking in the bill this next week that also, to further clarify our Practice Act, we're accepting amendments that exclude the practice of licensed educational psychology, marriage and family therapy, which actually is already in the bill, licensed clinical social workers, and licensed professional clinical counselors from the practice of occupational therapy. So we're very much trying to make it clear that occupational therapy is not in any way the practice of psychology, but more assisting patients and clients with coping with their mental health disabilities and how can they productively do their daily activities. So with me are Brian Edwards and some other OTs that Brian Edwards is the Vice President of OTAC, to share with you some additional information and some stories and answer some questions. Thank you.
Thank you all again for allowing us to speak. Again, my name is Brian Edwards. I'm the Vice President for the Occupational Therapy Association of California. I'm also the Manager of Occupational Services at Children's Hospital Los Angeles. So I'm sort of wearing two hats today. One from my OTAC hat, if you will. I wanted to just reiterate some of the things that Ivan said, that occupational therapy does have its roots in mental health and that moral treatment movement. But also, I think historically we've collaborated so nicely with psychology and psychologists, so we continue to value those relationships. And again, we want to maintain that. We don't want to practice psychology. We want to practice occupational therapy. And I think some of the advocacy efforts that we have engaged in over the last couple of years have been more about making sure that there's recognition for occupational therapists in some of those programmatic areas, so that we can be recognized as being able to provide services for people who are experiencing psychosocial or mental health issues. And so it really isn't about expanding our scope. It's about clarifying our role as occupational therapists. Now, putting on my manager hat, I just wanted to share a few ways that I see my staff providing occupational therapy services to our clients and their families that address some of the psychosocial needs there. So again, I work at Children's Hospital. One of the big areas that my staff work in is in the area of feeding. And for our infants, feeding is one of their primary occupations. It is like one of the primary activities of daily living. And so when they're working with a mother who is having difficulty breastfeeding because their child is unable to latch, or they're working with another parent who their child is having swallowing issues from the bottle, that creates additional stress within that dyad. And so even though they're working with the child or the infant to be able to improve that swallowing or that latching function, it really is promoting that overall bonding between the family. So we're definitely through that OT lens working on the feeding, but we recognize that it is a dynamic system, and that we can't necessarily separate the impact that we have there. We also have therapists that work in facial rehab, that work closely with a surgeon that does facial reanimation surgeries. And even though they're working on the physical fine motor skills of being able to smile, what we recognize and what the purpose of that smile is to be able to establish and maintain social relationships. Because when a 7-year-old girl gets to go to class and can smile for the first time to her peers, it increases her self-efficacy, her confidence, and her ability to establish and maintain those relationships with her peers. Some other ways that I see our staff practicing occupational therapy, but also addressing some of the psychological or mental health needs is we work with patients with complex regional pain syndrome, with conversion disorder. And again, it's always as part of an interprofessional team that has psychological support. But our focus is on the occupations and the occupational engagement and really promoting that ability to participate in meaningful occupations. So I really encourage you to ask questions if you have, but to reconsider your opposition, because I really feel like what this contemporization of the bill is really about defining occupational therapy and not trying to encroach on psychology. So thank you.
Okay, thank you. My name is Dr. Karen McCarthy, and I'm professor of psychosocial occupational therapy at Dominican University of California, as well as the chair of the Psychiatric Occupational Therapy Action Coalition. And I'm here to support some of the language that's used in the bill, AB 2221. Occupational therapy addresses holistic aspects of engaging in occupations, which are everyday activities. The meaningful occupations that each of us engage in have psychological and social components to them. The occupations of reading a book to a child, meditation, or taking a walk with a friend. They're physical, cognitive, sensory perceptive, and psychosocial aspects of performance. Separating the body, mind, and spirit would not reflect the significance and impact of this purposeful activity. Omitting psychosocial would be to misrepresent the power and scope of occupations. As occupational therapists, we have roots in psychosocial practice. OT was influenced by the mental hygiene movement and moral treatment movement of the 1800s. We were founded in 1917 with strong roots in mental health practice. One of our founders, Eleanor Clark Slagle, organized a therapy program in the state mental hospitals in 1918. Early supporters of occupational therapy included Adolf Meyer, who argued that we cannot understand an individual's presentation of mental illness without knowing how the person functions in the environment, and psychosocial assessment stems from this idea. We were also involved in community programs for people at risk of experiencing mental illness due to social causes such as poverty and life transitions. An example being the Hull House in Chicago, a settlement house for providing occupational therapy services to immigrants in 1889. We're not trying to expand the scope of what OTs do, but we are trying to acknowledge our deep history and practice of using occupation to improve the mental health and well-being of our clients. We cannot treat the whole person without acknowledging the psychosocial components of well-being. The psychosocial core of occupational therapy position paper states that psychosocial dimensions of human performance are acknowledged as fundamental in all aspects of occupational therapy, whether the practice occurs in a classroom, rehabilitation center, hospital, nursing home, or community. As occupational therapists, our tool and our therapy is occupation. We support health and participation in life through engagement in occupation. Engaging in meaningful occupation is the pathway to mental health recovery. We are doing therapy, not a talking therapy, but both are needed to sustain the mental health of our clients and communities. So thank you for listening.
Hi, my name is Shelby Surface. I am an associate professor of...
Press the, it is green. Thank you.
You can just fill that up. There you go.
I'll eat it. Here we go. Okay, how's this? Is this better? Yes. Okay, now I'm too loud. So Shelby Surface, if you didn't catch it the first time, associate professor of occupational therapy at the University of Southern California. I hold a director position at Children's Hospital Los Angeles within our, get ready, USC UCED. UCED stands for University Center of Excellence in Developmental Disabilities at CHLA, Children's Hospital Los Angeles. Okay, I think that was my 3 minutes. I just want to sort of get the word out and inform others of what I do and what the OTs on my team and the collaborators on our team do. We work primarily with clients that are receiving outpatient services funded through the Department of Mental Health. These are children, all children. They have sometimes histories of trauma, sometimes coming from foster care, sometimes from the hospital, actually quite a bit of the time having dual diagnoses, meaning when I say that, I mean they also have a neurodevelopmental disability as well. The mental health providers within we call it the USED, within the USED and on the mental health contract, oftentimes run into clients that they feel like they need some support outside of their scope. And that's often when they will then refer to occupational therapists, either myself or other OTs on our team. And we work together. We do co-treatments, we collaborate, we provide consultation, and then we step back and we allow those therapists to do what they need to do to help that child meet their mental health goals. Sensory regulation oftentimes comes into play, especially when we're talking about early intervention. And even with some of the older teenagers, we are able to provide services within the community, within their homes. A 16-year-old that had a history of trauma and significant trauma and abuse, and also has an intellectual disability, and her grandmother is getting older, wants to do the laundry and is capable of doing the laundry, as long as there's someone there to support teaching her how to do that and teaching her grandmother how to help her do that. It was not necessarily within the scope of the licensed mental health provider to do that. So the occupational therapist really we focus on occupation, and we happen to be working with some of the times a population that has a primary health diagnosis. Thank you.
Good afternoon. My name is Elizabeth Cheng, and I'm a assistant professor at Samuel Merritt University. All my lovely Southern California colleagues have come, so I had to represent Northern California, as you know. So it's my pleasure, and thank you so much for accommodating us in your agenda this afternoon. We really appreciate it. I've been a practitioner since 1985. I always tell students, you do the math, as I date myself. But I've been a practitioner in occupational therapy and mental health settings in particular since 1985, in acute settings and also in community-based settings and non-traditional settings. And I just want to give you one example. Many times I would have on the team a psychologist colleague. Typically it was nursing, of course, a psychiatrist, a psychologist, social worker, or a case manager, and myself. And again, I think we work very complementary because, for instance, you all are so dignified. I'll say malodorous. We were always sent the clients that had malodorous problems because they said, let the OT deal with that, because, as you know, body odor is a social component where folks cannot stand to be around the patient. They cannot get work because it's limiting for them to be able to go out and work and find gainful employment. So they would always send folks that had body odor issues to us. And we happily took care of that. I remember one patient in particular saying, Beth, I take a shower every day. And we'd always, say, this was always private because of the person's dignity. Or we'd have classes or in a group around hygiene. And I'd say, well, tell me, what your routine is. And he'd say, well, I use soap and I use hot water and I shower every day, and I use a washcloth and all this. And I'd say, okay, well, let's figure out what's going on. And sure, come to find out, he did use soap and water, hot water, and he did shower every day. But what was ending up happening was he was really low income and did not have a place to wash his clothes. So he was basically going into, okay, this is Beth speak, wearing the same funky stuff every day, right? So that was what the problem was. And because we're occupational therapists, we took the time to figure that out. Because if you just spoke with him, the issue was that, he doesn't know how to properly bathe. But it wasn't that. He was perfectly capable of that. But he was limited in his setting, in his money status to be able to, get clean clothes and have another set of clean clothes. So again, I think we're a very pragmatic, very practical occupation, and we're much needed on the team, along with all of our lovely colleagues. So I think, again, that's an example of how occupation, the layperson's term, nobody ever says, they never know what occupational therapy is, right? Because it's kind of a misleading term. Many people have said, I'm retired, Beth, I don't need occupational therapy, right? Because normally when we say occupation, we think of work. But the way that we use it is what occupies your time, what makes you get up in the morning, what motivates you in life. And so we don't have a cookie-cutter response in terms of what kinds of activities we do with the client. We really talk with them about what's important for them and meaningful for them to live their life. So again, thank you so much for this opportunity, and I hope you reconsider.
I just wanted to clarify. Missy Johnson is who you spoke to? She's the head of the California Association for Applied Behavioral Analysis. She's a lobbyist, actually. But she's not a lobbyist for psychologists. That's applied behavioral analysis. That's not a licensed profession.
They also have They also have the California Psychiatric Association.
But that's not psychology.
I understand. Understood.
Yeah.
And I understand for my mistake. It does. I guess I just really wanted to make the point that what we tried to do was put all of our language out in the bill early on, which it was in February, and it has not changed since then. And so, with the idea that we would put it out there so that we would get comment, we would get feedback, and this is the first. This point of the year is the first time that we've had any feedback that there was a problem.
I'm sure you understand that the concern for psychologists, separate and apart from what the board does, is scope of practice. So the fact that you talk to other professions doesn't necessarily address the scope of a psychologist's practice. But be that as it may, one of our primary concerns is, to me, in reading your bill, it appears to me that you are talking about being mental health providers. And as much as I respect what occupational therapists do, I do not know that I feel comfortable with the idea that you are a mental health provider in the same way that a psychiatrist or a psychologist or an MFT is. So that's where our concern stems from, because we're concerned that true mental health services that are focused purely on mental health really be provided by people that study specifically mental health and get licensed for it for the benefit of consumer protection. So I understand that historically this represents what you consider to be the natural scope of practice for you, and I also understand that occupational therapy can have a tremendous impact on somebody's psychological functioning. But to me, that's saying something different than we provide mental health services.
And I would, I'm sorry. I was just going to say, and one of the ways that has already been addressed in current law and what is oftentimes utilized, and we're doing it in our bill, is to put in exclusions in the Practice Act and many other professions do this as well, rather than getting too granular on what on the scope and what the services are. There are always exclusionary clauses in many, most practice acts, and certainly in ours, that say what the practice of, and in this case, occupational therapy, is not, as a safety net, to say that occupational therapists are not authorized by law to practice psychology or the other things that are listed.
But just to clarify, but you are saying you're mental health providers.
I just want to point out, I'm not texting, I'm on my phone, but I understand it's a different organization, but if I'm looking at the Department of Mental Health and their codes manual and looking at what different providers are and what they're called, I'm specifically looking at their definition of occupational therapist mental health. Occupational therapists provide treatment for people recovering from a mental or physical illness to regain their independence and stability and to engage in normal daily occupations, work, home, family life, school, leisure. Occupational therapists provide particular emphasis on interventions that result in improved quality of life and decreased hospitalization. I'm bringing that up because that's been there for I don't know when it was for many years. And so that's how we have been operating. And I don't anticipate this as a change in any way whatsoever, but rather bringing the language up to current practice. Go ahead.
So first of all, I want to say I became acquainted with my first occupational therapist when I was working at a psychiatric hospital a number of years ago, and we worked together to help patients I worked with to achieve the best functioning they could achieve in their lives. So I absolutely understand that the things you do impact people's mental health. When I read this bill, however, it doesn't read even like you're saying it. When I read it, it reads like, for example, if I just look at through engagement in everyday activities, occupational therapy promotes mental health and supports functioning in people with. Just that, even if you said by supporting functioning in people with psychiatric disorders instead of and, that would read to me more like what we do has an overall impact of improving people's mental health. And I think that's what, when I read it, that distinction isn't there. So that's the concern. It doesn't read, I think, like you intend it to read. So.
A comment that I might make is the materials we have include quotes from the American Occupational Therapy Association, and one part of a quote is, mental health is a component of all occupational therapy interventions. Occupational therapy practitioners provide mental health treatment. For me, as an individual, that at least starts to raise a little bit of a red flag, because when you treat, normally you have a diagnosis. The question is, who does the diagnosing? And it gets a little muddy, and there's questions, frankly. I know that that's not necessarily your position, but this material is part of a national association that's quoted here. And I think is a piece of our concern. I should have started off by saying that I very much appreciate the comments all five of you have made. I can tell they are genuine, and that you are here to inform us, and that's appreciated.
Can I?
Hi. Go ahead.
Oh, I'm sorry.
I'm sorry. You go ahead.
I was just going to, back to the previous comment about the clarifying and saying promotes mental health by supporting. Would an amendment like that potentially change address the concerns of the board? I mean, obviously you haven't talked to my client about this, but would something like that? Right. Got it.
I'm not speaking for the board. I'm just saying, I'm just giving an example.
Right. Understood.
I don't think it's reading like you really intended.
Mm-hmm. I understand the process. I guess why part of why I'm asking is because we are up against a deadline. We have until next Friday to amend our bill, and if something as simple as changing that to by supporting functioning, I can't obviously speak for my client, but that at this point, without talking to them on certainty, but that seems like something that we could seriously consider amending in the bill.
Well, it sounds like that was one of the issues, but for me as a public board member appointed to this board, and I love children's, go children, CHLA. But it goes along with what Dr. Erickson was saying, and I am a healthcare and community relations person, advocate, and that mental health, what's on your website, it is, to me, it's just very misleading about, that you provide the mental health treatment and prevention services. So I look at that as well, just me personally, and that's what concerns me, is just how it's represented. And but I also appreciate what you all do as an occupational therapist. I just wanted to make that clear.
I wonder if we said that we provide occupational therapy services and treat, is that because the way that we treat or provide services is through occupations? So maybe if we just, I mean, I love saying occupations, so we just keep putting it in there. But like that, we're not providing mental health treatment, we're providing mental health occupational therapy treatment and occupational therapy services. And with that exclusion that we are not practicing psychology.
Could I say that seems to be helpful, at least for me, as well as when you use psychosocial rehabilitation efforts rather than psychosocial treatments, which speaks more to psychotherapy from what I've understood. So I guess maybe even just that kind of clarifying. And again, as staff, we apologize for it being so late. Psychosocial is now on our list of words to look for. We would have got it earlier otherwise. So we're glad to have you here to talk about it. And I brought it up to the author as soon as we knew something. So hopefully we could have this kind of a dialogue where it wouldn't be a problem.
Right. And I think it seems obvious. It seems clear to me that we have similar concerns, obviously, from the perspective of we don't want to give the impression that we're practicing psychology. We want it to be clear that how occupational therapy services support the mental health, and so. I think there's a way, it feels like, based on this dialogue today, like there's a way to clarify in our language and get the best of both worlds, where we're addressing your concerns about I call it scope creep, and then at the same time addressing our goals of trying to recognize that there is a connection between occupational therapy services and somebody's mental health.
Dr. Erickson, I think there's another member of the public who wishes to take
Thanks. Okay, well,
Do you think your comment would better fit in here or later?
no, after she speaks, it's fine.
Okay. Dr. Gellin Akram.
Hi everybody. I'm Dr. Gellin Akram, the Chief Executive Officer of the California Psychological Association, and I just want to echo other comments about appreciating the work that occupational therapists do, of course. I do want to clarify a couple of things just in terms of process. So the organization that you reached out to, that you referenced, the National Alliance of, that's an organization, I didn't actually recognize the full name. It's mostly referred to as NAP. That's an organization that was started years ago to advocate for prescriptive authority for psychologists, and that organization does not represent the profession of psychology. At the national level, that would be the American Psychological Association. But the American Psychological Association also wouldn't really be involved in a state bill. The California Psychological Association, we have about 4,000 members and represent the interests of all licensed psychologists in the state of California. I don't believe that you reached out to us. I just was communicating with my lobbyist. Our board has taken a position on this bill, which you will see coming forward, but it's a little late in the game. But I don't believe that you reached out to us, which might have been helpful on the early end of this, because we have similar concerns that the board does about the nomenclature, the language, and the issues around scope of practice. So I just wanted to clarify that for future reference, and I would, in fact, encourage you to reach out to Amanda Levy, who's our lobbyist, because we're really the organization that lobbies on behalf of psychologists and psychology in California.
I very much appreciate that, and thank you for that clarification. And regardless of where we are timing, I think it sounds like we can figure this out.
Any further, Dr. Winkleman?
I'm also with the California Psychological Association, and I previously worked for the American Psychological Association for about 9 years, which is the national organization that represents psychologists. So I would recommend, again, I would like to echo many of the excellent comments about we absolutely appreciate the work that occupational therapists do. but I really resonate with the concerns that have been raised, that there's a major difference between having a positive impact on a patient's mental health, which is a very important impact, and calling yourselves a mental health provider. And so with your national outreach activities and positions, stating that you provide mental health treatment and prevention services is something that I think would cause a lot of, might get a lot of pushback. I've been working in this area for about 15 years. I've never seen occupational therapy referred to in any list of mental health treatment providers, not meaning that it wouldn't have very positive impacts on mental health, but it's a very different thing to say that you provide mental health treatment and prevention. So I'm going to also, I also suggest you reach out to the American Psychological Association, particularly if you're looking in other states as well, to redefine your scope of practice.
Is there further public comment? We now have a board member comment, Dr. Horn.
Yeah, I just wanted to clarify too, when you talk about, what do you call it, creep, practice creep, scope creep?
Scope creep, yeah.
Yeah.
Not a professional term of art.
Again, a difference between the board and, say, the California Psychological Association or the American Psychological Association. Our concern is consumer protection, and so it's not. It's more about how people are represented to consumers and what might confuse consumers. And if consumers might go to someone seeking mental health treatment and it's not someone qualified to provide mental health treatment per se. So that's where the board is looking from, that aspect or that standpoint, not from...
Right, and that's very much understood.
Okay.
We in our own Board of Occupational Therapy, very much the same. I mean, it is the same. They look at it from the perspective of consumer protection, and we've worked with them this year on our own bill with concerns that they've raised that we've addressed through amendments. So 100% appreciate that.
Mr. Fu?
It's a procedural question. So my understanding is we have taken a oppose unless amended position prior to the lunch break. And so my question is to everyone, and do we need a reconsideration of the vote if we want to go that path and delegate authority to staff to negotiate amendments? I'm not saying that's what I would. I'm just suggesting and thinking through what the next step looks like. Looks like Ms. Marks has my answer already.
A couple comments, and then perhaps we can figure out how to move forward. I know Mr. Altamura. He knows me because, as you know, I represented the Occupational Therapy Board for many years, but I have told that board that for this issue I represent this board because of any possible conflicts. I wanted to put that out there. And without sort of tying Mr. Altamura's hands, because as he said, he has to go back to his client, perhaps the board can first vote to reconsider their earlier motion, and then if that were to pass, vote on potentially different amendments, which Mr. Altamura, may or may not be able to sell to his client, but would at least allow the board to move forward with providing options that they would find acceptable to acknowledge that the work of an occupational therapist does indeed have a positive impact on mental health, and yet is not the practice of, they're not mental health providers. So I don't know if it helps the board in moving forward.
I'm curious from the staff perspective, does that address the concerns raised by staff in the analysis?
That does address my concern. So as long as we get some clarifying language that you guys are okay with, and then we can also work with Mr. Altamura.
So let me seek some clarification here. We could reconsider our motion. Then we could have a discussion about the amending language that you would take Mr. Altamura to your client and vote on that. Do we have the time to do that as part of my question?
That's a heck of a question. Do we have the time not to do that right now?
It seems important if we can do it.
I think we can. We're going to have to probably truncate a large part of the report as to other legislative items, but I don't think that will be particularly problematic.
Okay.
Particularly to things that are kind of a spaces, so a watch basis.
We'll probably pass the watch, yeah.
I think it would probably be useful to press it.
In that case, would the chair of the committee welcome a motion for reconsideration?
I would.
So I would move for reconsideration of our previous action on item 22B1.
Second. So now we have, I believe, we're undoing the motion, if I understand. Is that right, Ms. Marks?
Correct. This would just allow the board to bring it back for additional discussion.
So we don't need too much discussion right now. We're just going to undo the motion.
Correct. This is just whether or not you're reconsidering your prior vote to oppose unless amended as the amendments were put forward by staff.
Okay. So we have a motion. I did the second. I think we could proceed with the question.
Go ahead, do the roll.
Yeah.
Okay. Badu? Oh.
Okay, public comment on the motion.
For reconsideration.
Basically, we're trying to withdraw the motion we made earlier, which was to oppose unless amended. We want to vote on that, and part of the procedure is to ask for public comment before we vote. So is there any public comment? Anyone? Seeing none, I think we're ready for a vote.
Okay. Badu?
Yes.
Bernal? Erickson?
Aye.
Fu?
Aye.
Horn?
Aye.
Phillips?
Aye.
Motion passes.
Good. We're back to square one plus.
So, I'm
Please.
sorry.
Go ahead,
Dr. Erickson.
please.
Just to pick up on Mr. Fu's comment about whether or not you want to suggest additional language or just delegate it to staff. I'm not sure we've done that before. We've delegated to staff for. I didn't think so. So one of the I can throw out an idea based on what I've heard discussed, and you can start from there, or somebody else can throw out an idea.
Dr. Horn did suggest it by instead of and.
So to pick up on that, potentially oppose unless amended to, or you may even consider a support if amended, to read through engagement in everyday activities, occupational therapy promotes mental health by supporting occupational functioning in people with or at risk of experiencing a range of, I don't know if you want to put physical and or mental health disorders. Does that help get across the idea that you're
It's from the perspective of adding physical there, I don't know that that's a problem. It is previously referred to in 2 lines up from there that are also highlighted that says occupational therapy addresses the physical, cognitive, psychosocial, sensory perception.
I think my suggestion there is just
To
to get at
clarify
the
that-
idea that you're promoting mental health,
Right.
or you're helping support the mental health by your work with occupational functioning in both people with physical disorders and mental health disorders. It seems to me that someone's mental health would be improved by assisting in their occupational functioning, whether or not they've been diagnosed with a mental health disorder. So that was my suggestion there. You can go from there, or somebody else can throw something out. So that's what I'm offering to assist the board.
Did you also want clarification on psychosocial and the psychosocial rehabilitation or any other variant of that?
I think that's fine. I don't have a problem with psychosocial. I don't know if y'all do, but I mean, anybody who works in healthcare assesses psychosocial functioning, and so. Do y'all have a problem with that?
No,
So-
in the context of the changes
Yeah,
we discussed.
yeah.
Okay.
Yeah.
Just making sure.
May I add? And just for clarification, Ms. Burns, I think you had mentioned earlier that MFTs were added as an exclusion, and I just wanted to draw the attention to the board that psychology is already included as an exclusion in the language, so that that addition wouldn't be needed because it's already in the bill. That that the provision they're excluding excluding psychology is already there. Just wanted to draw the attention to that since it was mentioned earlier.
Yeah, I think it's more just the idea that we don't want this to appear as we want to recognize the fact that people's mental health is definitely strongly impacted by things that you're doing. We don't want to make it sound like you are mental health practitioners, that you can hang up a shingle, people come in and do talk therapy with you.
And we don't want to do that.
You can talk to them, but
And then
I
you
like
just,
Ms. Marks's suggestions.
Can you read it to us again? I'm a little confused about where we are in terms of the actual document. I'm looking at the document that Ms. Burns created that shows the proposed amendments. You're looking at an actual copy of the statute.
I'm looking at the hard copy of the materials. So let me see what section that is.
if you scroll up a couple, you'll see without it struck and through where we've just highlighted the areas of concern, the highlighted yellow underlined text.
What page is it on the
I think it's
combined
On your combined document, it's on 160.
package? Okay, thank you.
So
Oh,
on page 160, it just highlights the areas of our concern as staff, and that would be easier
Okay.
for you to read without the strike-through
Gotcha.
language.
Gotcha.
Just makes it easier for them to see. It's visual.
Or 164, which I think is the bill itself.
So that,
That's-
for our purpose on these tablets is tiny.
Right. Okay.
Yeah, I was going to say.
You'd have to wear magnifying glasses. 160, 159.
Can I read how I've written it down to make sure I've?
Would love that.
Okay, so how I heard what Noreen said was through engagement in everyday activity.
Where are you in the document?
I'm sorry. Well,
It's on page 160.
Yeah, I'm looking at the report. Yeah.
The second highlight in 160.
Okay, thank you.
Okay. Through engagement in everyday activities, occupational therapy promotes mental health by supporting occupational functions in people with or at risk of experiencing a range of physical and mental health disorders, including but not limited to psychiatric, behavioral, and substance abuse disorders.
My suggestion stopped with disorders to get away to get away from what might be considered diagnoses that are provided by an OT, but it was just a suggestion. So, and again, I think the board is aware that you can't promise what your client will or won't do, but my suggestion was possible amendment of through engagement in everyday activities, occupational therapy promotes mental health by supporting occupational functioning in people with or at risk of experiencing a range of either adding physical or not mental health disorders. And I'm not sure, period, exactly, because I'm not sure why we would add the psychiatric, behavioral, and substance abuse disorders. If you could maybe explain to the board what you think that adds to an explanation of what the practice of OT is without going too far down the road of being mental health practitioners, maybe the board would accept that.
I can at least speak to the behavioral piece a little bit, at least in pediatrics. From a reimbursement standpoint, there has been a lot of reimbursement is it's a big driver, right? But especially in the world of working with children with autism, because it is considered by many payers a behavioral diagnosis, and so just acknowledging that occupational therapists do provide services to children with a behavioral diagnosis.
But that is a mental health disorder, right?
I would not split hairs over it, but some people do.
Okay.
Yeah.
And I think I could address the substance use because we also see through activities, again, folks with co-occurring disorder. So we just want to make very specific around psychiatric diagnoses, which can also, and substance use disorders, which are sometimes often seen through a different lens.
Dr. Phillips, you've been taking some of the lead on this, and I'm realizing that I'm at idle here for the moment.
I would feel more comfortable with it if it stopped at mental health disorders, personally. Because I certainly want to acknowledge that you do things that impact mental health disorders. When you start adding on these additional categories, which I understand have implications in terms of funding and reimbursement and so on and so forth, again, it starts to sound more to me like we're talking about a mental health practitioner who is diagnosing mental health disorders and treating mental health disorders. And that gives me pause.
But I just have a question. I'm sorry to interrupt, but just when you add substance abuse disorders, are you talking about a patient that, let's say, is got mental health issues, bipolar or something that's psychological or psychiatric, but yet because of his addiction to, let's say, other drugs, or if he's addicted to other types of prescription meds or something like that, that they cannot fully function at their full capacity to work? Is that kind of within that context of why that's in there?
Even substance use disorders are in the they're mental health disorders in the diagnostic and statistics.
But I was saying, though, in terms of the role of what they do as occupational therapists for someone that, let's just say, has that challenge.
So,
Miss, I'm sorry, Dr. Bernal, okay, Ms. Bernal, I know at least from the community-based piece, we serve pro bono. We send students to serve clients that could not afford occupational therapy. And my understanding is in some instances in acute psychiatric settings, or sometimes even in order to get treatment, oftentimes the client has to be sober to be able to receive some psychiatric treatment. And so I believe on the community-based end, we can serve the clients because they have a I'm so nervous I just lost the word. Where you can still use and still take advantage of the services. I totally forgot now. I froze. But so we just make that distinction because we don't make the qualification that you can't be using and still receive services as long as you're not assaultive to anyone or things like that. So I guess it's a matter of splitting hairs, and this is my starting point as an occupational therapist. It never occurs to me that we could diagnose, because in order for us to see a client, we have to get the word from you all, right? And so the fact that we mention these diagnoses has no bearing on. We know we can't diagnose. We cannot see the person unless we have a doctor's referral. So that just gives me pause. And as you all mentioned in the DSM-5, yes, all of these things are mentioned, and they have their own pages and pages of criteria. But
I wonder if there's another way to approach this, which would be using the original suggestion from Ms. Marks as to adding language, maybe including but not limited to something like the occupational treatment of or occupational functioning related to psychiatric behavioral. And that to me, again, feels more clarifying so that so we all know where things stop and start. By the way, I'm a psychologist. I work with substance abuse. I take people that are actively using all the time because sometimes that's the only way you can access those people. So I don't think there's a set rule about that in our functioning. Would that sound more like something that would, I don't know what the exact language would be. You're an occupational therapist. I'm not, but occupational functioning relative to psychiatric behavioral and substance abuse disorders?
Occupational therapy relative to occupational. Can I take another stab at trying to reread the whole sentence? Okay. Through engagement in everyday activities, occupational therapy promotes mental health by supporting occupational functions in people with or at risk of experiencing a range of physical and mental health disorders, including but not limited to occupational therapy relative to psychiatric, behavioral, and substance abuse disorders.
That sounds good to me.
Can you say that
All right. Okay. Yeah. Backwards.
Functioning, not function.
Occupational function.
Well, you could do
Functioning's fine.
Function or occupational function. I guess occupational function.
And where? In which? Here.
You read it.
I read it right. Okay.
If we,
all right.
if we get that close on it, I think we're good.
Okay. All right.
That we can, yeah.
Okay, one more time. Through engagement in everyday activities, occupational therapy promotes mental health by supporting occupational function or functions in people with or at risk of experiencing a range of physical and mental health disorders, including but not limited to occupational therapy relative to psychiatric, behavioral, and substance abuse disorders.
Sorry, can I add one more little wordsmithy thing around this functioning? Can we say occupational performance?
Sure.
That better aligns with our practice framework. Okay.
We all have our own unique
I know,
language.
right? Yeah.
Would the chair of the committee welcome a motion adopting a position?
Oh, we've commented. Well, we can do the motion and then comment.
Well, a clarity question: would the position of the board be oppose unless amended with the language suggested, or support if amended with the language?
I would prefer support if amended.
That is up to you.
Well, if the language change wasn't made, then I would be opposed to I personally would be opposed to the legislation. So if the language change was made, so to me it's an opposed unless amended situation, because then we're back to the confusion relative to what exactly is being done and how that impacts consumers in my mind.
So perhaps like.
It isn't support if amended, only if it's amended do we support it?
But then,
It doesn't convey the opposition
then
point.
We're not in a position to oppose the legislation if none of these changes are made, correct?
I would suggest you do have the authority through your administrative procedures manual for the chair and the executive officer in coordination with you to make that change where if the amendments were not made, and you could use that administrative procedure manual procedure for this sort of a wonderful event.
Okay, well, support if amended sounds more positive, so I'll go with that, even though it goes against my nature.
We very much appreciate.
I would suggest then to the chair that I'm happy to make the motion of support if amended position on AB 221 by Assemblymember Bloom with the articulated amendment as discussed.
Second. Any discussion by board members? Public input on this. Dr. Winkleman?
Maybe I should move back over here. Hi.
Talk about creeping.
Exactly. Elizabeth Winkleman, CPA. I have to say I'm a little bit confused by by this language still, in the sense that, to me, and I am not an expert. I'm an expert in mental health, not in occupational therapy. It promotes all the things that are already in the language, previous paragraphs. It promotes health, wellness, physical and mental well-being, and affects physical and mental health well-being and quality of life. It does all of those things beautifully, and I just don't understand really why there would be this focus on mental health and mental health disorders And to me, I find it confusing, and I don't understand why it would be in the scope of practice language, or why it's needed. It doesn't really add anything to the scope of practice, unless it's there in some way to support this idea that's in the supporting material of providing mental health treatment and prevention services, which we would really have concerns about. So anyway, I just wanted to raise that as a concern, and I didn't really understand Ms. Burns's point about what support if amended, and then you'd have to go back. I mean, I think the decision for the board is if you oppose unless amended, then it needs to be amended, or else it's opposed. And if that's whatever, it's the board's decision. But I think you're saying it wouldn't have the same impact if it's support. Obviously, if it's support if amended, or oppose unless amended, and that. I don't really understand the other point that you'd have to go through.
I think what you're saying, Ms. Burns, if I can intercede, is what we're saying is if the language is not amended, then there is within our administrative procedure manual a means by which, in consultation with the executive officer and the chair of the Policy and Advocacy Committee, we can then decide to oppose the legislation. So we can change our position to it oppose if the amendments are unsuccessful. Correct? Yep. Yeah. So we'd prefer to take that position, from what I can tell from board sentiment. But
and I just have to make a quick addition that I think Mr. Altamura, having served as a chief of staff to two leaders, clearly understands what a verbal commitment looks like, and I certainly have faith that we can work this out based on the motion on the floor and the administrative safeguards we have in place for that. So from my perspective, I feel comfortable moving forward with that perspective, and knowing Mr. Altamura's past achievements. So.
And I would just suggest on my behalf, we already have the sponsor of the bill here and attempting to work with us. Had it been earlier in the process and we had no commitment at all even to go back to his people that he's representing, then oppose unless amended would have been my only recommendation. So, but we already are having a conversation and hopefully can have resolution within the week. So.
Okay, thank you.
Any other public comment before we bring this to a vote? Seeing none, I think we're ready to call the question.
Akwe-Badu?
Yes.
Bernal?
Aye.
Erickson?
Aye.
Fu?
Aye.
Horn?
Aye.
it was a cliffhanger. Wow.
I don't like that last little bit we added. I wanted to end it at mental health. A range of physical and mental health disorders. I think the other is declarifying to my mind.
Okay.
It clarifies it somewhat because it talks about occupational functioning, but to pull those out, I just find mental health disorders encompasses all of these things. And then otherwise we're talking about payors and stuff like that, which we don't have anything to do with, and that concerns me a little bit.
So, Dr. Horn, you're suggesting that if the author decided to amend the bill and leave that last phrase out, you'd be happy with that, and you assume the board would be also?
I'd be real happy with that, but I don't want to. I kind of. I'm in a minority here anyway on the board. I'm just saying that's just my one little caveat, and that's why it took me a while.
So your vote is aye?
Yeah.
Okay.
Well, I was going to abstain, but I hear now.
You can abstain.
I'll abstain.
Okay.
Mr. Altamura, hearing the conversation here.
We're still voting.
Oh.
Dr. Phillips hasn't voted yet.
I will not be forgotten.
Hard to forget always.
And Phillips?
Aye.
Motion passes.
Mr. President, may I make a comment?
Absolutely.
Quick question, Mr. Altamura. I mean, hearing the conversation here that Dr. Horn has raised, would it be possible to talk to your client? I mean, we've just taken the position, but talk to your client to see if we could end it there and go from that place.
I will definitely take that back to my client. Yes.
And hopefully, well, I'm quite confident that we've conveyed our sense of support to you, and by the way we've worded our motion, that we would like to support the bill, and if it's not amended, we would have to oppose it.
We very much appreciate you revisiting this. Took a lot of time, but obviously it's important, and it's extremely important to OTAC and AOTA, and it's been a long time coming for us, and so thank you very much for giving us the opportunity.
Thank you very much for coming.
Thank you very much.
And just one thing, don't forget who represents psychologists. And
I will not. I will never forget. I'm giving them my cards right now.
Maybe you need to get theirs.
Yeah, I will. That was the plan.
Okay. Okay, people. Shh. Dr. Erickson.
Thank you. Continuing with the legislative update, I thought I would add a sort of introductory comment at this point. We're probably going to quickly look at the recommendations to watch bills. We'll look at a couple of the items under review of bills with active positions. We don't plan to look at those bills with watch status already approved, and there's a number of those bills. We will spend time on statutory revisions to Section 2960.1. We'll get to the regulatory update, which will be fairly quickly done. I wanted to mention this in case board members or public members had a particular bill that they wanted to speak to or ask about. This would be the time to voice that interest before we dive into things.
Can I make an alternative suggestion?
Sure.
Why don't you go through the bills you're intending to go through, since we don't know what those are?
Okay.
And then if you've missed a bill that we wanted to say something to, people could bring up the bill.
Perfect.
Does that make sense?
Yep. Okay. B2, the recommendations to watch bills. These are fairly self-explanatory. We are recommending they be watched. Are there? Excuse me. Almonds.
Do you need emergency intervention?
I think I'm okay.
Okay.
Thank you. Are there comments from board members on this section?
I'm sorry, we're on.
This is small b number 2, recommendations to watch bills.
22B2, including AB 1971, 2302, 2324, 2608, and SB 984 and SB 1298.
Oh, thank you.
Ms. Bernal, did you have?
Oh, no, thank you. We're good.
So hearing no or seeing no comments, I think we will move then to the Part C, which is review of bills with active positions taken by the board. Number 1, AB 282. Ms. Burns or Mr. Glass-Beagle, either of you want to quickly introduce this bill?
I'd be happy to. AB 282 would codify that any person whose actions are performed in compliance with the provisions in the End-of-Life Option Act cannot be prosecuted for those actions under Penal Code Section 401. In May of 2018, the board voted to support AB 282. As of the 7th of this month, this bill is pending concurrence in the Assembly, and the board will continue to advocate in support of this bill.
Great. Any comment on this? Public comment? Let's move to AB 2138.
AB 2138 narrows the board's discretion to deny a professional license to the following cases. An applicant that has been convicted of a crime, the applicant has been convicted of a crime, limits denials based on a criminal conviction to convictions for which the applicant is presently incarcerated or that occurred within the preceding 7 years, except for convictions of a serious felony. The applicant has been subject to formal discipline by a licensing board within the preceding 7 years based on professional misconduct that would have been cause for discipline before the board for which the present application is made. I'm not going to read this whole thing if it's okay with everybody, as this thing's quite long. But the board has taken a opposed position at the May board meeting. Since then, the legislation has changed a bit, and it has broadened from, and Sharice, you may remember the terms a little bit better than I do, but it's now serious felony versus a violent felony. Additional changes were...
There was, it went back to the more, substantially related instead of directly and adversely. Thank you. I'm like, man, there's some words losing the moment.
Yeah, right.
Losing my words. It does still have some of the provisions, though, that would require us to have regulations in order to revoke, stay the revocation, and then put people on probation. That option was currently in the general business and professions sections as an option B of the variety of different actions you can take. Now it would be one of the options that the board would have to deem appropriate, which means essentially adopt regulations in order to use. So we would have to adopt regulations in order to use the current process we're already using because they're striking that language. And then a variety of other provisions. They've taken out some of the biggest, costliest ones, which was the appeal process, a secondary appeal process when people already have an appeal process. So that took out the need for the multiple extra board meetings, although we already need extra multiple board meetings for our petitions right now. So some of the things have changed and gotten a little better. The biggest concerns are still sitting there, along with additional regulatory changes that are needed. The serious felonies adds a few more felonies to the list, but obviously there are still concerns about things like fraud and other dishonest behavior that wouldn't be covered under those. So those are all things that if we were to continue to use them, we would have to use regulations. But according to this, we still would have the time limit of 7 years?
Yes.
7 years, and no use of underlying acts, and also anything under 1203.4, so it was dismissed by the court as rehabilitated. We would not be able to consider that either. So those are still stripping quite a bit of the authority. We only deny about less than 1% of applications already. The concern here is that I believe it's 70% of those denials would be we wouldn't be able to use 70% of that data that we currently have used for the small number of denials that we already do. So it further restricts what we can use on a very already small and limited population. So overall, still really bad. It is sailing through the process. It just got out of appropriations the other day, yesterday actually, because I was sitting and watching it while listening to you guys in between. So it's sailing through the process, and they didn't have any stakeholder meetings in July. They are going through, and they don't have a need for a stakeholder meeting, is my guess. So they don't need to meet up with us that are in opposition. So this most likely will be heading to the governor soon, unless somehow it has a really weird floor vote.
Clarification. I'm not sensing that there's any need for us to write a new letter that states things differently at this point in terms of our opposition.
I think the overall opposition is exactly what we'll talk about. I think we'll be a little more explicit in our letter to the governor about specifics and talk about why those are important, how our practitioners are behind closed doors with their patients, and how some of these things may seem minor to others, but these are really important problems. Medi-Cal fraud, why that wouldn't be already on there, why we wouldn't be able to use that, and different things. This just essentially makes us have to go back to the rule book again and specify it in regulations with what we already have as the option to use. So, I mean, don't hamstring our enforcement capabilities and our ability to protect the consumers. So, I mean, we'll get a little more specific for the governor to identify in a longer list of issues, but I think an oppose is the only place you go. They're not looking to amend right now. There's no need to try and go there at the moment.
Okay. And staff is ready and has the authority to write a new letter for the governor when the time comes? Good.
And just an addition point of clarification, or just to let the board know, we go to regular legislative roundtables with the Department of Consumer Affairs, and at the last meeting, we were sitting around the table with other boards and bureaus, and there definitely seemed to be a consensus in the room, even those that did have an oppose unless amended position. There were some serious concerns that were expressed, and I think from the standpoint of the agency and the department, there was an encouragement that if we do have concerns, that we articulate those and express those to the administration once the time comes. So I think if the board, wants to keep the current position, that we stay that course and continue to articulate, that this is a solution looking for a problem. I think when we look at the less than 1% of our applicants that are denied that go through the process, we're not talking about a lot of people here that aren't able to enter the profession. And I think on the other side of it, what we've heard is, well, there are people that are too afraid to come and ask, but how do you quantify that? So I just want to kind of throw that out as some additional information that we've heard and sharing with the other boards and bureaus. So,
thank you. I don't think we need a motion on this. Is there any public comment that would be warranted at this time? Warranted. Desire? Does anyone want to make it public? Why don't we assume that we're going to keep our position of oppose unless amended, and we can go on to the next bill, which is 20.
Yeah. Oppose.
What did I say? Yeah, sorry.
Dr. Erickson, I just want to say I do know of at least one board who has tried to offer some amendments because of, as far as I know, because of a desire to try to mitigate what they see as the impact of the bill. I'm not sure if this board has any interest.
Yeah, thank you. Mr. Glass-Beagle, would you touch on the remaining bills under Section C?
Absolutely. The next bill is AB 2143, which relates to the Licensed Mental Health Service Provider Education Program. This bill, as amended on June 11th, would expand the program to apply to persons eligible under existing law who attain further education in order to practice as a psychiatric mental health nurse practitioner or physician assistant in psychiatric mental health setting, thereby allowing those practitioners to apply for grants under the program for reimbursement of those later incurred educational loans, but paid for by the fund of their psychology license. At the May 2018 board meeting, the board voted to oppose AB 2143. Staff is not recommending any change to that position at this time, but if the board should have any questions, I'd be happy to answer them.
We also were recently reached out to by OSHPED to ask about our position, so I conveyed our concern to OSHPED. They are the agency that operates the Loan Education Fund, so DCA and OSHPED are both well aware of our concerns, so they can be included in that message to the governor.
No questions? Okay. Next bill is AB 2943. It's an unlawful business practice sexual orientation change effort bill, and it would include as an unlawful practice prohibited under the Consumer Legal Remedies Act, advertising, offering for sale, or selling services constituting sexual orientation change efforts to an individual. We have the definition of sexual orientation change efforts below. At the May 2018 board meeting, the board voted to support AB 2943. Staff has been advocating in support of the bill throughout its legislative process. As of the 16th, it's pending Assembly concurrence, so it went from the Assembly through the Senate, and now it's back to the Assembly for an agreement on the final version of legislation, and then it should, if concurrence is reached, it should be off to the governor. Any questions? All right, the next bill is SB 1125. It's a federally qualified health center and rural health clinic services bill. And currently, a patient of a federally qualified health center or rural health clinic can only see one healthcare practitioner, aside from a dentist, in a day. The bill would allow Medi-Cal reimbursement for a patient receiving Medi-Cal services at an FQHC or RHC, which is rural health clinic, to receive both medical services and also obtain mental health services on the same day they receive the medical services. The board voted to support this bill in May. And the staff is not recommending a change to that position. As of the 16th, this was on the Assembly floor.
It was voted out of appropriations yesterday, so it is off to the floor.
Yes, so. Assembly floor. And we will send a support letter to the Assembly floor.
Good.
That concludes
Very
this
good.
section.
Thank you. Any comments before we move to the next section, which is D, and I'm going to recommend that we mention that these are bills that have an active watch status. Is there any comment from board members on any of these bills or from the public before we go to the next section? Seeing none. We're now on item E. Ms. Burns, could you please tell us where we are with this?
So, in this discussion, it was at the February board meeting, we decided to bifurcate that process to where the current 2968 is just about the brochure and when to hand it out, and that this effort would be to talk about sexual behavior in the context of discipline. At the Policy and Advocacy Committee meeting in April, there were revisions to that language added for consideration for the board. So the Policy and Advocacy Committee want to recommend to the board the addition of for the purposes of sexual arousal, gratification, exploitation, or abuse to the sexual behavior definition, so that the definition would read: sexual behavior means inappropriate contact or communication of a sexual nature for the purpose of sexual arousal, gratification, exploitation, or abuse. Sexual behavior does not include the provision of appropriate therapeutic interventions relating to sexual issues. This language puts it a little more in conformance with the other language on touching of an intimate part and sexual contact, so that way it's in that context of for the purposes of, instead of just any and all sexual behaviors or things that might be construed as such. So this is up for your consideration. After this, the original plan was to take this to a stakeholders meeting to get more input on the language, and then potentially run this as a legislative proposal after that point. So obviously it would go to the stakeholders and then come back to the board for final approval. As such, we're requesting that you review and revise the language that's provided in the materials, and then delegate to staff to use these revisions to start that discussion with a stakeholder group.
Good. Dr. Horn?
So on these examples of inappropriate sexual behaviors, so just so I can understand it, if you say inappropriate, this first topic or heading, inappropriate contact, does not meet statutory definition of sexual contact. If it doesn't meet the statutory definition, then what does this mean for these behaviors?
Those behaviors under current law would be a boundary violation and not sexual misconduct.
And so with a change, that would be sexual misconduct. Is that?
That's what we're trying to
Right.
define it as. So
Okay.
sexual behavior and in that sexual misconduct context.
Can you read the definition of sexual contact for the board members just so they know the difference between the two?
Absolutely. Let me grab it. I, of course, do not have it open at this very moment.
Can I just ask a question while you're doing it? So all of these on this page are behaviors that we'd like to have included in the definition
I think
because
those-
they're all inappropriate.
They're all inappropriate behaviors that currently don't meet the sexual contact or touching of an intimate part definition, I believe, is what
Okay.
we're trying to get at.
All right.
Ms. Monterrubio, would you come forward just for a minute to discuss this? So could you explain the concern from the point of view of the enforcement staff?
Well, I think with the examples that we have here are pulled directly out of cases that we've seen. And again, as Sharice just stated, they haven't been alleged as sexual misconduct. It has been boundary issues. And so because we're seeing repeat acts that fall in this area here, we just think that we need to have specific information as to the grooming behavior and this type of behavior here.
And if I understand correctly, part of that is because the Attorney General's office, in looking at materials where we're looking to bring a complaint, have advised us that under the existing definition, which would not be the definition we're talking about here, they were not sufficient to rise to the level of the definition as it exists in the statute now.
That's correct.
Okay.
So, just so we know, sexual contact means sexual intercourse or the touching of an intimate part of a patient for the purpose of sexual arousal, gratification, or abuse. Intimate part and touching have the same meanings as the Penal Code 243.4, which is touches means physical contact with the skin of another person, whether accomplished directly or through the clothing of the person committing the offense. As used in this section, the following terms have the following meanings. Intimate part means the sexual organ, anus, groin, or buttocks of any person and the breast of a female. Again, so that would exclude touching of the breast of men or someone that identifies as male. So, there you go.
Where shall we go with this? Mr. Tomplay, would you like to?
Thanks. I'd just like to address briefly the point that the President made. I don't think that I or the Attorney General's office has said what was represented. It's my general understanding, and I don't speak for the Health Quality Enforcement section, but it's my general understanding that we have ample authority under existing law to charge all manner of sexual misconduct, and I'm actually not sure that we need any revisions to accomplish that. So I just wanted to correct the record. We haven't taken an affirmative position on the need for revisions and further.
I don't think you haven't represented that you have.
Oh, okay.
The concern is there have been cases where we've brought the specific behaviors that are listed in this list to the Attorney General's office, and they've informed us it needed to be prosecuted as a boundary violation and not sexual misconduct.
I understand.
For instance, if somebody took pictures of their genitals and sent them to their patient, that does not fall under that definition as I understand it. And yet, it's pretty egregious sexual behavior.
Sure, and for example, that type of egregious misconduct could be prosecuted as the most extreme type of unprofessional conduct that we can charge, which is gross negligence. And so that could result in the revocation of a license under our existing laws.
But are you saying it currently would be like a boundary?
Well, it would be treated more as a gross boundary violation, I take it, because it wouldn't be sexual conduct.
So the laws as they're written now have a variety of ways that could be charged. It could be charged using the APA Code of Ethics as the standard of practice, and based on that, violating that would be most likely an extreme departure. It could be a simple. And so based on that type of charging, it could result in a revocation.
Although not as likely to result in a revocation as it would if it were charged as sexual conduct.
Well, when you charge it as sexual conduct, it triggers, I think, a automatic. Right? Is that what the board may be interested in, the automatic revocation? So it would take discretion out of the ALJ's hands.
It would take discretion out of the ALJ's hand, but would retain the discretion on the part of the board. So we could still get an ALJ's opinion and feel that it did not rise to the level where it should result in revocation, if I'm correct.
That's right.
And we could therefore decide to proceed differently with the decision.
That's correct.
Okay.
So I like the clarification and would like to, make the changes because it's not been infrequently that there have been what I would consider absolutely sexual improprieties, but that wasn't charged. And then we've seen people who've been put on probation because there wasn't, because it wasn't actually sexual, and then they're going to be coming back and practicing in that whole issue and even misunderstanding sometime that what they did was sexually inappropriate. So was never gotten by the person who was being disciplined. So that clarity, I find, I'm just in favor of clarifying it or including these behaviors.
I find it helpful as well, and I guess what ultimately I'm reflecting on is the experience of enforcement staff with these cases. I think they feel sometimes stymied or frustrated by the way that it needs to be approached. So based on our enforcement experience around egregious sexual behavior that is not sexual contact, I think there's strong impetus for making these types of changes, or at least considering them and taking them to stakeholders to get their feedback.
Further, Ms. Burns?
I was just checking if you were going to public comment or if you were having more board conversation.
Do you need a motion from us?
I do.
Maybe we could have a motion and then go for public comment.
Would anyone like to make a motion that we adopt the language as shown for 2960.1?
I would vote to adopt the language and.
Oh, so you're moving it?
Can I?
Yeah.
We need a motion, so I'm asking if someone would like to make a motion.
Yeah, I would like to move into motion that we adopt the, where are we here? Language in 2960.1.
Great, thank you.
And move forward with the stakeholder meeting.
I'll second that. Is there board discussion? Public comment?
That's no, Michael.
Well, it's late in the afternoon. I was giving ample time.
Why is this soliciting public comment?
Very good. I think we're ready for a vote.
Okay. Akwebudu.
Aye.
Bernal.
Aye.
Erickson.
Aye.
Fu.
Aye.
Horn.
Aye.
Phillips.
Aye.
Motion passes.
Wonderful. A point of clarification, Dr. Phillips, will you be forming the stakeholder or getting that put in place?
It would be the Policy and Advocacy Committee on Informed that would arrange for the stakeholders meeting. I'm sure the executive officer would be happy to interface with you around arranging those dates.
I'll be reaching out to you with hopefully getting a broad array of stakeholders for that meeting.
Very good. Here's some discussion here. Is there anything that informs us further on this? Okay, good. Are there any suggestions from the board or the public for legislative items for a future meeting? This is agenda item 23. this time of day it is the right time.
Hello, yes. We would like to request, Elizabeth Winkleman, CPA, we'd like to request an item for consideration. I think it would probably, and again, correct me if I'm wrong in the procedural side of this, for consideration by the licensing committee, I think in October, and then by the board in November, in connection with the pathways to licensure, to consider adding an exemption in the licensing law for neuropsychology testing technicians, also sometimes called psychometricians. It's come to our attention recently that this is a potential issue for our neuropsychologists. Testing technicians are recognized. They're supervised by licensed psychologists. They're recognized by the National Association for Neuropsychologists as a standard of practice to use these. They're also recognized in the CPT, the current procedural technology, I think, codes for billing, and also by the Centers for Medicare and Medicaid Services as a billable, as their services being billable under the supervision of a psychologist for neuropsychological and psychological testing. So we would like to request that that be considered. As I said, I think it would need to be the licensing committee and then the board.
Thank you. Is that clear enough for licensing and staff to consider as an item for our next meeting?
Yeah, I think so. I'm not sure exactly where it would go, or would we be able to add it into our pathways consideration? Or if we have to...
I hesitate to say this because this is a policy call of the board, but this sounds more akin to a scope of practice issue, which we can, as a board, advocate if there's an existing bill. Perhaps if CPA wanted to find an author, that might be something to then, once it becomes a bill, share with the board, and then if the board wants to take a position and become involved at that stage. The pathways to licensure is really about, getting the experience, applying for licensure, and what does that process look like? This sounds more like a scope issue, which isn't really something that has been addressed during the pathways. I'm throwing that out there from the staff perspective, understanding that this is a policy call of the board to make, but an advisement from staff.
And I was going to ask the clarifying question that were you hoping to run a bill, or maybe this was intended for future agenda items that aren't on the agenda right now?
Oh, I was asking if it could be a future agenda item for discussion in connection with, and this is where I had wanted advice from you all. I thought it would be something that might be able to be added as an amendment to the licensing law as part of the whole revisiting of the pathways to licensure, because we're looking at all kinds of trainees and people who are working under the supervision of, because it's not changing the scope of practice, but it is allowing a different category of supervisees. However, if that's not permissible to consider it in that manner, then I would certainly be glad to bring it back to our board of directors for considering that we find a sponsor and develop a bill.
And just for clarification, Pathways to Licensure is really about training opportunities that lead to licensure. It's not just kind of anybody that works in the field of psychology.
Right.
So it doesn't quite neatly fit within Pathways, I think. But I think certainly the board would invite you to bring this to us in some form, certainly worthy of consideration.
Would it be something that licensing would look at, or not? I'm just asking a question. Where would it belong for us, like as a board?
I would recommend that it would belong as something, if it was a bill, to be considered by perhaps Policy and Advocacy Committee and then ultimately the full board if CPA was going to author or sponsor legislation. Just because this is a scope issue, typically boards don't author scope issue kind of bills. That would just be staff recommendation.
So it's my effort to make sure that it was going to get placed somewhere that we would be able to get it on the agenda has turned into maybe it needs to be a bill for us to consider, if I'm understanding correctly.
Okay, that makes sense, and I very much appreciate the board and the board staff input and recommendations to how to proceed. Thank you.
Can I just ask a question?
Mhm.
Are neuropsychologists concerned about this category, or
They are, yes. They have asked us to take a
are
look
they
at
worried
it.
about? I mean, are they doing anything that runs afoul of? Is that kind
Well,
of what?
they're concerned that it's not clear right now whether it's permissible to use technicians or not, and they would like it to be clear. Nobody wants to run afoul of the licensing laws.
Yeah.
So the idea of making a change would be to clarify that it's permissible.
And just a clarifying question, Ms. Monterrubio, do we see complaints? Have you heard of complaints about this area? No. Okay.
And Dr. Winkleman, if you wouldn't mind just passing along any of that information, that'd be great, just to have a heads up on the issue.
Oh, you mean if we develop a bill?
Yeah.
Or, yeah.
Or
Oh,
even the concerns that people are relaying right now, so we can take a look.
Okay, yes. Thanks very much. Thanks.
Thank you. Other suggestions for legislative items for a future meeting? Seeing none, I think we're ready.
Dr. Erickson, I
Yes.
say this on behalf of myself as an aging member of the population. Could we take a 5-minute restroom break and then come back to the regulatory matters? Thank you very much.
Of course.
One last chance to gavel. Dr. Erickson?
Thank you. We're now on item 24. Mr. Glassbeagle, could you give us a quick run-through, please?
Thank you. Included in your meeting materials is the list of the board's regulatory packages and their status in the regulatory process. An update to this list is the retired regulations was submitted to legal for their review on the 13th of this month. So all regulatory packages are in legal's hands right now pending review.
Great.
Any questions?
Thank you. Pardon me?
Oh, right. I'm sorry. Thank you. And for the specific amendments to our potential amendments to our telehealth regulations, I will turn it over to Ms. Burns.
Ms. Burns is looking confused. By
No,
the
I
charge.
think I can. There was a hand carry on telehealth provisions. Is the language also outside in print? Can you grab them for the board members? Because I believe Ms. Marks brought up some concerns to the board, and yeah. Okay.
Oh, okay.
We'll get the papers coming in here. Just that hand right there. So Ms. Marks brought up some concerns about the language, and I believe the necessity of the last sentence on A, whether or not it was necessary, and some other considerations for the board to take a look at before we proceed with the regulatory package, because this would also require us to modify the ISOR, but we wanted to make sure we were covering all of the aspects that we believed we were covering with the adoption of this language. And I'm going to hand it over to you, Deidre, for your concerns.
As I was reviewing the initial statement of reasons on this proposal, I thought, well, I looked at the language and I thought, okay, I think we can simplify things as I understand them. And because when I looked at it, I started to get a little bit confused about what we were trying to address. And in my recollection, what we were trying to address is people who are getting treated here, then maybe they're on vacation somewhere else and they want services via some means of telehealth. We were also discussing, as I understand it, people, for example, the example that I remember is a student who's going to from New York, for example, is here going to university, getting started with a mental health practitioner or psychologist, goes back during holidays or during summer break, and the board was concerned about continuity of care. You know, maybe snowbirds, people who live part of the time in California, part of the time in another state. So I didn't see the need to talk about the initiation of services, because that's how I understood what we were trying to get at. Somebody who is either domiciled here or a resident here, and then needing services and wanting to use telehealth to effectuate the continuity of care. I'm not sure I have all of those circumstances correct in what the board is wishing to address. So that's why it's back here, because I've recommended some changes, which my attempt was to simplify the language.
So the highlighted language is the language that Ms. Marks has marked up for the board to consider to address those concerns that came up in reviewing the initial statement of reasons.
And I have the document in front of me for any changes we'd like to make right now.
And my deletion of patient or was done at the suggestion of the staff that that's the way the board is going, not because I was making any determination there.
I just noticed a little typo in B.2, just from the patient, or just strike out or. Should just read client.
Mm-hmm. I wanted to offer a comment or two to try to operationalize this in a sense of what I might say to another psychologist colleague who asked, hey, what can you do with telehealth? And as I understand the language here is that a psychologist would be allowed to use telehealth for anybody who's in California, and you can continue to use telehealth for somebody that you've started with here who's out of California, provided where they're located also allows that. I think that's the gist of what our language states. Does that match your impression, Dr. Phillips? We've had discussions on what is and what isn't.
It does. We had a discussion about this in preparation for today's board meeting, which you were not privy to, and I was involved in because of president, as to whether that last sentence of the first part of subsection A was really necessary, given that if someone came into California and received services in California, that's certainly permissible under a California license. If that person's not a resident or domiciliary of California, and they then return to their home state, it really becomes purely a question of whether that state allows that treatment to continue. It's not really within our jurisdiction.
Well, I would say that in any case, it's always going to be dependent upon the laws of the state where either the client or the licensee is located. So that's always going to be true, but what I understood, and maybe it was a misunderstanding, but what I understood initially that the board was trying to cover were those people who have some ongoing relationship with a therapist here because of the fact that they live here. Either they've made this their permanent home or they live here for some specified period of time and then are going back. Not necessarily the example of I'm here solely to seek services and then I'm going back.
Because I do think that situation exists. where someone comes to the state, they might come here for a residential rehab program. They might come here because there's somebody that's a particular expert in a particular area that they want to treat with, and they then do at some point leave. And for whatever ongoing care there is or continuity of care, there might still be contact either through telephone or video. But I'm not really sure it's necessary for us to clarify that situation here. Part of the reason I think we get into a little bit of confusion about the telehealth regulation is because part of the impetus of this was that psychologists really felt like they had inadequate guidance from the board as to what was permissible and what was not permissible. On the other hand, I don't think we need to make pronouncements about things that really aren't kind of within our jurisdiction, so to speak. So I guess in my mind, and maybe I'm completely incorrect about this, Ms. Marks, if somebody came to California while they were receiving service here, if they had a complaint about the service they were receiving here, it'd be perfectly appropriate to come to the California Board of Psychology to make that complaint.
Yeah, absolutely.
Okay. If they left the state and continued care with that person at a later point in time or resumed care with that person, but never returned to the state, I would think that relationship would be subject to the licensing laws of the other state in which they're located, but maybe I'm wrong.
I'm not quite sure I'm focusing correctly on your question. I think in any case, even if you're talking about somebody potentially who lives here and has simply gone to another state for vacation, is reaching back, and the other state may say you are reaching into their state for practice, I think that person, if they have an ongoing relationship here, they're going to complain to the California board anyway. But I think we're still saying it's subject to the laws of the other state. I don't see how you cannot. I think the issue, though, of someone going back to where they're if they've simply come here for services and are going back, you're still a licensee of this board. They could still complain to this board. I think the question is whether or not this board was saying, we think it's okay for you to essentially be engaging in that practice interstate with someone who doesn't have that contact with California.
Ongoing relationship with California.
Correct. Okay. And that's what I'm not sure of. That's where I think I diverged and where I chose to amend the language, but I may not have that accurate in what the board was trying to address.
My sense was that initially we thought that if we had a patient in California that we're treating, that we had some, hopefully, right to continue treatment when they're out of state. And that no longer seems true, as I understand this, that we don't have a special right, that we have to comply with the laws of the other state as well as our own state. If I'm understanding where this is headed, for example, somebody that comes in for treatment is one area, another is an ongoing patient that goes on vacation. And I can think of an example in my practice a number of years ago, and it never occurred to me to consider the jurisdiction where the patient was temporarily located. They wanted telephone therapy. They needed the support. I provided that. I checked with insurance to see if they would pay for it, but I didn't know enough to check with the other jurisdiction.
And I agree with Ms. Marks, so that within what the examples that you were bringing up from a continuity of care is a conversation that I remembered from our last initial, board meeting where this all came up. And it was the student, like, for example, that, or maybe started with a therapist here and then, or with their psychologist and then moved back and wanted to continue.
That was in my memory as well. If someone, one of the students is back for a break, because and maybe I'm misremembering it, the discussion of if that person now has cut their ties with California, at some point it would be within the responsibility of the psychologist here to transfer their care to another psychologist. So I thought the initiation language just got a little confusing and I wasn't really clear what the purpose was, except to address those situations where somebody's here, for example, like for college or a snowbird who then goes elsewhere. And I thought, well, I think we've addressed that by saying the person is treating a resident of California, somebody who has a sort of some ongoing contact here, even if you're not domiciled here. So that's where I tried to tighten it, but I may be tightening it too much.
This became kind of a conundrum for me as I was thinking about it. And I'm really thinking, I'm not sure that last sentence of the first part of subparagraph A is really necessary, the one that you deleted. So all I can say is, for reasons that are not even entirely clear to me, I'm comfortable with the deletion of that language.
Perhaps we could get input from Dr. Winkleman. I don't want to presume that you have a lot to tell us, but I think you might.
Hi. Hi. Yeah, I wanted to again thank the board. I think this is such an important issue, and that this is really going to be expanding so much as we go forward. So I'm concerned that there are situations that I understand the initial intent, which makes a lot of sense, which Dr. Erickson was talking about, that if you start treating somebody, you should be able to continue if it's clinically indicated. However, I don't think, as Dr. Erickson also mentioned, that we can't fully, California, the Board of California can't guarantee that. They can only say it's fine with us if it's fine with the other board. So I do think that is covered in this current draft. My concerns are that there are some other situations that are not covered, and that in fact, as it stands, this could further restrict what people can even do now. And so I'd be concerned about that, especially thinking in a forward-looking way for the board to really consider how is this field of, mode of delivering services, telepsychology, going to be expanding and developing. Because right now, people can already do this. I think they already do this, and they check with, now there's more awareness of it. They may check with the other board to see, is that permitted? Similarly to the way that other psychologists will check with the California board. So people are already allowed to do this. With this language, though, it then seems like it would wind up cutting out some other situations, because by saying, well, you can do this if a person starts therapy in California or is a resident or domiciled in California, to me that's implying, well, if they're not domiciled or a resident, then you can't do telepsychology. And there are people who, as we've discussed, say they come here for a temporary purpose, to go to school, to do an internship, to have a job in a temporary way. Well, that would not come under. They would be here for a temporary purpose. And so this would actually wind up then being restrictive, because that person who's, say, coming for a summer internship or even a 2-year graduate program, then they go back to Massachusetts or whatever. And then this would say, well, but you can't treat that person by telepsychology because they were not a resident or domiciled in California. And even beyond that, I'm wondering if what the board intends is that a psychologist could never initiate therapy by telepsychology. For example, let's say I was a super expert in some very unusual area, but that was appropriate for telepsychology. And this is not just the telephone. Many people have HIPAA-compliant audiovisual setups, and this is becoming more and more common. The way this is written, again, this would exclude someone from seeking therapy who's coming in from out of state. Let's say the other state says, yes, you can practice for up to 30 days as long as you have a license in another state. Then this would prohibit that person in that other state. Let's say the person's in Massachusetts. They really want my expertise. They'd want to do it by HIPAA-compliant audiovisual conferencing. They're not a resident. They're not domiciled. And this would imply that you can't do that. So, so that's I'm very concerned.
That logic escapes me. And I understand somebody reading this might see it that way. I think what we're saying, these are the things that we can permit you to do as the California Board of Psychology. If somebody wants to practice interstate psychology with non-residents of the state, and they just want to have a practice where they have a national consulting practice, and they've got clients all over the country, I don't think that falls naturally within our bailiwick. I think that is a question of practicing interstate in interstate commerce.
Well, but that person who's sitting in their office, I'm
That's
a
a federal
California
question.
psychologist, right? Then under this, it's saying a licensee is permitted to provide psychological services via telehealth in these situations.
Right.
It's restrictive. To me, these situations are restrictive. And if you're saying as psychologist, you as a board would still be, you would have control over the psychologist, because the way these laws have been interpreted in other states and by the commentators in this area are that the psychologist is practicing psychology both in the state where the psychologist is licensed at the time that the services are being provided and where the patient is located at the time that the services are provided.
And I guess what I'm saying is, I'm only speaking on my own behalf.
Mm-hmm.
I don't know if it's a good idea for the board to be authorizing our licensees to practice interstate with people that have no logical relationship to California without there either being some legal or pact mechanism for that, and we're going to get to SIPAC later, or it's somehow regulated. To me, that's not a transaction that's purely about California, so I don't know that we want to take a particular position on regulating that at this point. So these are the situations, I think, in which we felt comfortable with, and maybe I'm misspeaking, so certainly feel free to correct me, Dr. Erickson, where we felt comfortable that people would be using telepsychology and it would be with the full authority of the board, subject to the laws of the other state. These other areas, I'm not sure if this board's ready to move forward saying, if you've got a California license, you can practice in any state you want to, subject to their laws, and we're somehow carving that out as a sanctionable or a permissible activity.
And I just want to address one thing. I do think in my research on residency and domicile that a student who's here, if somebody's here for a 2-year internship, they would be considered a resident of California, even if they're not domiciled here, because you can have multiple residents, even if you only have one domicile. So I felt fairly comfortable that the board was addressing that situation, which I thought had been brought up several times as an example. And beyond that, I think the board could sort of talked about, well, would we want someone who's licensed in Massachusetts to be reaching into California to California residents without a California license?
They are doing that, and they're permitted to for up to 30 days per year. They're doing that right now.
But because there's an exemption for a temporary practice.
As do the other people, other states, as in this regulation, the draft, it says you're still subject to those other states' regulations. So I think everybody's clear that, we can't, the California can't. So nothing that this board would be able to do would obviously be able to change what the other states' board is doing.
Dr. Winkleman, are you, I'm not sure, but are you saying the part about domiciled or residency is a snag and that maybe we'd be better off to not have that mentioned at all?
My concern, I read this as more restrictive than current practice and confusing. I mean, I think it's confusing and more restrictive. Even if it weren't a student, so I understand Ms. Marks that certainly you could make the argument that it's not temporary or transitory if a person's a student, but maybe they're just doing a summer internship. Maybe they came here for 2 weeks to seek some kind of intensive therapy with a specialist in California. Maybe they have a job assignment for 2 weeks and have a panic attack and go see a psychologist. So there certainly would be people that would fall through the cracks. So it's up to the board to decide what kind of regulation they want to have. But I see this as potentially, I read it as more restrictive than current practice and a little bit confusing. And if that's the intent, then, that's the board's discretion. Well, I mean, the restrictive part of saying only in these circumstances would the board endorse any California licensed psychologist by doing telepsychology.
Where does it say that?
Well, it says a licensee is permitted to provide psychological health services via telehealth to a client who is a resident of California, temporarily located outside of the state. So if you're saying, if the regulation says you can do telehealth in that situation, and does not mention any other situation, to me, I would be very nervous as a psychologist to say, well, but it doesn't mention the other, so I guess I can do the other thing too? I mean, by not mentioning the other situations, it implies to me that those other things are not permitted, because if this is the standards for telehealth and it says you can do it in this circumstance, in these circumstances, you're a resident or you're domiciled, and then...
Well, here's the dilemma.
Yeah.
And I don't want to speak on behalf of all the board members. This is the way I'm thinking about it.
Mm-hmm.
We've been asked to say when we feel comfortable people practicing telehealth. I'm not ready to say some of these other situations I feel comfortable. I'm not ready as the Board of California to say, oh, you sure, practice with people from Massachusetts. It's cool. We're all good with that. That's a big policy leap in my mind. In the same way that I think we would have a real problem with Massachusetts saying, oh, yeah, go ahead, deal with the California folks. So that, as far as I'm concerned, at least from the point of view of our committee, we never made a determination that we were saying, giving the go-ahead on that. I don't think this necessarily says, it doesn't say you're not permitted to do anything that's not listed here. It's just telling you specifically what, based on our current thinking, you're permitted to do. There's certainly other things that people could do and choose to take the posture that they feel comfortable doing that. But I'm not sure that the California license necessarily authorizes them to do that.
Dr. Horn, I don't mean to put you on the spot. I'm just curious as to what your thoughts are on how you're interpreting this.
It's just confusing to me as I read it a little bit. So that's part of the problem for me, because I mean, what we can do is regulate the practice of psychology here and telepsychology here. If somebody moves outside of the state, I'm not talking about going on a vacation or anything like that, but even if they've started treatment here for something special, but then they move outside of the state, and somebody here who's been seeing them wants to follow them, then that person who wants to follow them is absolutely going into the state where that person lives, even if treatment was initiated here. So then the psychologist here has to make sure, and you're right, people can, in all the states, they allow at least 30 days of temporary practice. That's allowed. But beyond that, then things, if there is something beyond that, something has to happen with that other jurisdiction. So we're not saying anything other than that, right? I mean, I'm a little confused now.
I think that's why I was, when I was working on the initial statement of reasons, and that's where the board is going to explain its policy and why it's doing what it's doing, where I started to look at the language and try to narrow down what I thought we were saying. Dr. Winkleman, I'm interested if what you're saying you think should be allowed. To me, it sounds like then sub A just goes away. Why would you even need it? You're saying, go ahead, practice telehealth. Oh, by the way, just follow these conditions.
Yes, and subject to the laws in the other state. And here are our conditions. You need the informed consent, and you need to take all these considerations factor in all these considerations if you're going to do it. And I also want to clarify another point. One of the board members asked, with the California license, the other states under the temporary practice provisions allow you specifically to say, if you have another license in another state, you can practice in our state. So that's already there. But yes, you're correct. I mean, I think that unless it's the board's intention to restrict what people are doing now in terms of the interjurisdictional stuff, A could go away, and then we just say subject. It's okay with us if it's okay with the other state, as long as you do what's in B and C.
Yeah, I know the board has been struggling with this for quite some time, and I know there's an interest in moving forward. So, I'm clearly open to, this is the board's call. this was my recollection, I do ask the board to bring it back to what your mission is, which is to serve the people of California. And I do ask the board to consider what it would take to try to bring any kind of enforcement action against a licensee here when there's no more contact with the state of California, and how would that affect your enforcement program as well? So, this was just my offer to streamline it the way I saw what I thought the board was after, but there are really policy calls on the part of the board.
I mean, I do think our charge is to protect the California consumer. I don't feel comfortable getting into a regulatory situation where we're talking about a psychologist relationship with somebody that has no logical nexus to the state, other than the fact that they're on the telephone with somebody from California. So to me, this does express what our intention is. That doesn't mean people can't do that, but I don't know that it logically falls within our charge to determine California psychologist's relationship with non-residents of the state. We're not in the business of protecting non-residents of the state unless they come in within the state to get services.
Dr. Phillips, just to that point, because I just want to be sure, I think you've raised a really important point. So you referenced before that California psychologists are asking for guidance. I think they're asking for guidance because they're licensed in California.
Right.
So they want to know what this board has to say about whether they, as a licensed psychologist in California, can do with regard to telehealth with people who are somewhere else. So I understand what you're saying, and if the board opts not to comment on that, in other words, just to stay out of that completely, then I don't know. It leaves a void. So it leaves a California psychologist. I guess it leaves them just saying, well, your board is not going to comment on what you can do except in these circumstances. If you want to do those other things, you're going to have to, you've got to get guidance from somewhere else.
I don't think we can give in a regulation a comprehensive list of things that psychologists in California can do that don't relate to California consumers or California residents. So,
but you're
that's what I'm
licensed.
saying. If you want clarification of what we think is permissible and is regulable within our scope, this would be, to my mind, this is it. This is my intention in originally being on the telepsychology committee. I'm not going to, our job is not to opine on other situations that I don't feel
No,
fall
I know,
within
but
our
your
charge.
job is to opine to your licensees about what's allowable and what's not.
But we're not here to give legal guidance to our
No, I
licensees as to things outside the
understand.
scope of our.
Well, I understand, and yet you take disciplinary action against licensees. And so I think that's where the desire for guidance comes. You know, we've talked earlier about, before, about the BBS guidelines that were adopted, which seem very clear and straightforward. I just wonder if it seems more complicated and more confusing than it might need to be. So that I'm curious whether or not there's been any discussion about telehealth at the DCA and whether or not there's any move toward just having a standard kind of, this is what DCA says about mental health practitioners. Has there ever been any discussion? Because BBS has one thing, we're going to have another thing. I'm just wondering, has there been any move to have just kind of in the state of California, the practice of telehealth is this. This is what you can and cannot do.
Mr. Glass-Steagall has something to add.
Unrelated to what you're saying, Dr. Linda Crow, I wonder if it would be if the board would consider it, and I totally see what you're saying, Dr. Phillips, about only wanting to have the language speak to patients that are domiciled within the state of California and maybe temporarily located outside. What about for something to be in the regulations that says that this is not meant to prohibit a licensee of the state of California practicing with a patient that's domiciled outside of the state of California? Just some type of clarifying language that clarifies that this only relates to a patient that's domiciled within the state of California and how to act with that.
I don't know that I want to get it. This is just me, again, my opinion. I don't want to get in the business of giving tacit approval to people practicing interjurisdictionally just to practice interjurisdictionally. That's me.
And I think this is a really fascinating discussion because, and an important one. And so you have a California licensed psychologist; they're your licensee under your jurisdiction. They do telehealth with someone who is in the state of Texas. What happens if that person files a complaint to this board because it's a California licensed psychologist? What happens then? And again, that's why I think people are asking for guidance. Like even if the board said you're free to practice telehealth with anybody else, and we're not going to take any disciplinary action. That is all up to the state where the patient is. I think that's what causes a little bit of the confusion, right? I mean,
but Dr. Winkleman pointed out that it's where the practitioner is and where the service is delivered both in many jurisdictions, if I heard correctly.
Well, I think you're right, and that's what I think we're all kind of saying the same thing, because it is where the patient is in that jurisdiction, and you have to follow. But then you also said it's where the person is licensed.
Right.
So because the person is licensed in California, I'm wondering if this board can just say hands off. And under those circumstances, can you really just say hands off? Because then I don't know. That maybe I'm thinking about it the wrong way too.
Well, I don't think we're going to be saying hands off. I think there's a difference here. We would most likely get a complaint and we would most likely close it, no violation, versus no jurisdiction. So that there's a difference. To me, the no jurisdiction is saying hands off. We don't have any part of this. But no violation is saying we're okay with what you're doing as long as the other state is okay as well. Does that make sense?
But I don't think. But I think you're saying, if I'm hearing you right, that you don't want to say you're okay if you're practicing.
Saying you're subject to the laws of the other jurisdiction. Right. You've got to figure out whether you're okay or not. We can't tell you whether you're okay in that other jurisdiction, and we don't have jurisdiction over a complaint that would arise out of a California
and that's where
psychologist.
No violation. But then what happens? Does that go on that person's record somehow?
Well, if a complaint is filed against anybody, that's not public information. First of all, it's protected under Government Code 6254. So we wouldn't disclose that to anyone. So because anybody, for any reason, disgruntled employee, ex-spouse, can file a complaint. So until it's thoroughly investigated and there's validity to that complaint, and let's say we were to take action, formal action or informal action with a citation, that becomes public, but not a complaint.
So then would it be true then that if somebody filed a complaint, and I'm just trying to be clear, if you're going to be silent on it, then I would think you wouldn't even accept the complaint.
Well, we accept
and
all
anything.
We look into every single complaint that's submitted to the board. So anytime we get written notification over the phone, we open a complaint. We may not have to investigate that complaint. We may not take action, but we open every single complaint that's submitted to the board.
And I understand that it seems a little inconsistent if you're going to say we're not going to comment on this scenario, and yet if somebody files a complaint against a licensed psychologist, you will open a complaint.
We have to open a complaint anytime anyone makes a complaint to us about anyone. It could be even,
for any reason.
Yeah, for any reason.
And I'm thinking, of course, we would have jurisdiction. That's probably incorrect.
Well, that's not what she's saying.
My microphone's on.
And I think Ms. Marks is going to weigh in with yet another opinion.
I don't know that we've had this conversation with enforcement and with the Office of the Attorney General, but I would think for a person who's licensed here and is practicing telehealth here, the board would. But I do think at some point it becomes a logistical issue of how do we enforce, how do we take an action where the person is 3,000 miles away, where the patient is 3,000 miles away. I think it makes it a logistical issue in addition to those other issues that we've discussed, which is the board's mission is, as I understand it, to protect the consumers of California. So that is what I understood the committee wanted to narrow it to. Otherwise, if it's you can do telehealth anytime you want, subject to the laws of the other state where you may be located or where the patient or client may be located, then A gets much shorter or goes away. And I think part of the struggle was how do we write A? What are we telling licensees that this board is comfortable with saying it's okay by us if it's okay by the other state?
Mr. Tomplay, do you have any input on this item? And I'm just curious if there's been any issues with the medical board. I can imagine there are people that have surgery here in California, and there may be some post-op or follow-up or something once the person goes. I'm just saying because we're all covered under the same telehealth section in the general provision. So did you?
Well, yes.
It's 2290.5. It covers
It's all under the same.
us, medical board, and BBS. Did you have anything to add to that?
I can approach, but just to be honest, I don't. I have not had any substantive interaction with telehealth cases for any board, so I can't offer any background information about that.
I just want to throw out there that while I think that's entirely possible, someone comes here for a medical procedure, goes back to their home state, maybe has post-op follow-up conversations. I think. Correct. Right. I think the practice of psychology, maybe more than any other healing arts, lends itself to the using this mode of delivery services to telehealth, and that's why I thought we were being a little bit more circumspect and informing licensees what this board was comfortable in saying is okay with this board. I don't see, and I don't know. I'm not a surgeon. I've never worked for the medical board, but I'm not sure that I see sort of post-op telehealth, interstate going on for long periods of time. I don't know. It could be, but I think because the nature of the practice of psychology, there could be interstate telehealth going on, and if you're going to say that's okay, why would there ever need to be an initiation of services while you're in California? Then why were we saying that? Just say interstate practice is okay.
Quick question here. The language says it's permitted, doesn't say only permitted. So it's permissive language, and I'm unclear why there's so much challenge around that. It's not exclusionary. The language, as suggested here, is a licensee is permitted, and then lays out what those standards look like. So it doesn't say only permitted. We're not excluding anybody outside of that. So is that correct? Is that a correct interpretation?
Seems like it, but legal is saying maybe.
Well, I think there are probably more variations on this theme of telehealth than we've talked about, and we've come up with lots of them, and I'm sure there is lots more that we could come up with. I do think that the point was to tell practitioners, this is what we're comfortable with saying is okay. Now, the board may get complaints on something that even falls within there that we never even considered. But I think at some point, if the board gets a complaint from the state of Massachusetts that a licensed psychologist, California licensed psychologist, is practicing without a license in Massachusetts, this board would want to take a look at that and not just say, well, it was okay with us. So, because if it wasn't okay with Massachusetts, I think this board would want to say that was outside of what we said it was okay, that just it's sort of a pure interstate jurisdictional practice.
Can I ask a question? Every state has allowances for temporary practice. How does this differ at all from temporary practice? It's essentially going into the state to practice temporarily, and we're allowed to do it at least 30 days in every state. Some states are 60 days of temporary practice. So how is this any different? The only difference is the means of the intervention. Why is that, again, any different? I mean, do we want to say more about our temporary practice? We can't offer advice to people about going outside of our jurisdiction. We can't offer that advice.
Clarification question that I have. Let's say a California psychologist goes to Texas temporarily to practice, and there's a complaint filed. Where does the complaint go?
Texas.
To Texas if they're practicing in Texas.
After 30 days. Is that depending on?
No. If it's a Texas consumer and they're practicing in the state of Texas, the complaint is a Texas complaint. It's not a California.
But if it's our psychologist who goes in for 30 days in Texas, could be either way. I mean, Texas has allowed us in, but if one of our psychologists breaks Texas's
that's a
licensing
different
law,
complaint,
then it goes to Texas.
I think it would depend on what the nature of the complaint is.
Yeah.
In part, I'm asking because it may also be that way with telehealth or telepsychology.
I don't know that
my
telepsych is any different, except that we have with telepsych you have certain privacy kinds of things that you have to attend to, and what happens if the telecommunications goes down and doesn't work, and what happens in terms of emergency. Those are the kinds of things that we have to think of if we're using telepsychological means, but otherwise it wouldn't be any different from practice if our physical body was the same place that the patient or client's physical body was, to my mind.
Here's my concern, and it's kind of come up in this discussion in a variety of different ways, is the suggestion seems to be to get rid of subsection A and just say what the rules relating to telehealth are or what the guidelines are as it relates to telehealth. I'm not comfortable authorizing, because that suggests to me you're permitted to do anything relative to telehealth, and these are the only things we're going to be concerned about. And that's not my sentiment. So
suggest that we would leave the part about obeying the laws of the other state, or they would be relevant.
But I think we're suggesting something that I think is beyond what I'm comfortable with. Yeah. That's all I'm saying.
So,
Dr. Erickson, that language is still in there, subject to the laws and regulations of the other state where either the licensee or the client is located.
If we take out A?
No, if we take out A. No, I'm saying that what you have before you, that language is still in there.
I guess I was thinking that if we take out A, how to address Dr. Phillips' concern that people can do anything they want.
It's already there, you're saying.
No. If we take out A, it's gone.
We could leave that and take out the rest of A, but it's still.
But then we're suggesting, to my mind, based on the way you're arguing it, we're suggesting any kind of telehealth you want to do is okay, as long as you meet these criteria. And I don't know that that's.
Is the question before us whether we're accepting Ms. Mark's yellow highlighted items, or has it now that conversation evolved to pulling back this item completely and striking out potentially A, which I know, Dr. Phillips, you're not comfortable with, because I think we're trying to have several conversations at the same time, and I'm trying to figure out a path forward. And so that's my question. What is the will of the committee, for lack of a better word, but what is the path we're looking to do? Is it to talk about Ms. Mark's specifically highlighted sections, or do you want to reopen this for a larger conversation? And if so, well, real quick, and if so, can we then set this item for another agenda, since it appears that they're okay? So, well, I will move then to adopt Ms.
Just for context, and you haven't been here to be privy to this, but this has been a subject of 3 sunset reviews. Sunset reviews are every 4 years, so this needs to be resolved before I die.
Ms. Sorek, because I do feel like you are immortal in every way, I think I'm trying to understand where folks are on this issue on the board, and it sounds like Dr. Horn, the 30-day provision is something that for you is the safeguard already. Is that where? Because you've repeatedly brought that up, so I'm just curious.
I don't see what we're specifying here. I mean, again, I get that we've been asked to do it, or we've said we're going to do it, or it's been part of every sunset, but what are we trying to say? Do we regulate the practice of telepsychology within the state? But isn't that essentially the same as the practice of psychology within the state? I mean, is it any different?
No,
I mean,
yes, because as we've said, that telehealth is as we say in the ISR or explain in the ISR, it's a mode of delivery.
Right, it's a mode of service delivery.
Right. So what I understood, what the board wanted to do, and what I was trying to do, is to say that for continuity of care purposes, the board, telehealth intrastate is not an issue, right? I think we're all agreed on that. Telehealth interstate, what I understood was that the board was saying it's a continuity of care issue with someone who, either resides or is domiciled here, has engaged in services here, and maybe out of state for some period of time.
Okay, then I'm going to say we can't say anything about that. And the reason why is because we don't have the jurisdiction outside of here. It is subject to what the other state says. So if the other state says, yeah, you can come in and you can practice temporarily, and we don't care how you do it, then that is fine. You can do it telepsychologically, or you can do it in person, or whatever. Then doesn't that satisfy?
Well, that's why we've left in there subject to the laws and regulations of the other state where either the licensee or the patient is located. So that has stayed in. And I think what I understood the board want to give guidance of is we understand the issues of continuity of care. We want to tell licensees we are good with that. We still can't say what the other state is going to say, but I think the limitations of the parameters of dealing with a California domicile or resident is that there was some protection there that California could still regulate and enforce the conduct of that licensee here, and that it would still be within California's interest to do that. So that's how I understood it. But
to me, it sounds like we're going in search of a problem that really doesn't exist. That's what it sounds like to me. I think the states do have ways that they do it. We do too. We would look at that. We allow people to come in here 30 days a year, or however we do it. Other states do at least that, same thing. And that gets worked out with the state. So if we allow temporary practice, and what do people have to do to temporarily practice in California? Do they have to contact the board? Do they have to let us know that they're coming? Do they have to do anything? How do we know they're temporarily practicing for 30 days in?
We don't.
We would know if we got a complaint. Yeah. Essentially.
I just want to add this to the discussion, and hopefully it is clarified in some way. If we were to take out subsection A, we wouldn't be saying to licensees anything you want to do is permissible, that, relative to telehealth. So there will be no guidance on that subject. It would be just simply guidance on how telehealth needs to be done from a California point of view, which is a possibility. We could do
what
that.
else what else would we want to say?
We were trying to help people in situations where somebody was residing or domiciled here and then went out of state. Would they still be permitted to do that under their California license? So I think we were trying to clarify that was permissible.
But I don't think we can actually say that.
Subject to the laws and regulations of the other state.
That's what we can say. Yeah.
We can say that.
That's all we can say.
I think we can all agree we can say that. But these other things I don't think we're ready to say.
Yeah.
Did Dr. Linda Crow, is that, because I thought maybe you were saying that your constituents were looking to us to tell them, or did I misunderstand that? Because then what I'm hearing, though, then we're all kind of in agreement that we're not going to say anything. I just want to make sure that we address your question.
I guess.
Well,
I don't know the kind of guidance.
I know.
folks are looking
I
for.
think that's part of the problem. I think you're right. I guess number one, I think Dr. Winkleman's point has been all along that we don't want to end up with something that is further restrictive than what we already have. That would be a bad thing. So in crafting all this language, if we end up somehow being more restricted than what is happening now, I don't think probably any of us want to end up there. I do think psychologists have wondered, and maybe it's just because the board has not commented. Like the psychologists have wondered, well, what about this? What about the student who is at UC Berkeley and goes home in the summer and wants to continue to see you because they do? And maybe the answer is what you're saying. Maybe the answer is you need to check with the state where the student is going to be. But is that, I mean...
Yeah, I mean, and that's what I do tell people now.
That's what we tell people now.
And everything I've read on this has indicated,
that's appropriate.
they have to check with the other state. Yeah.
What I don't want to happen is if we take out subsection A, that people mistake our intention in doing that to say any kind of telepsychology is going to be honky-dory, because I'm not sure that it is. So I want to be clear about that.
Anything
this is
isn't
not
hunky-dory.
Huh?
It's just like any kind of anything isn't hunky-dory.
But it seems to me then we're not really giving guidance on situations in which people are having this question, and maybe that's okay.
I'm wondering if it's not okay. I mean, I'm thinking the guidance is already out there.
The guidance is check with, subject to the laws and regulations of the state where the patient is located.
We don't state that explicitly, though, and I think that's a key issue.
And I think you're right. Maybe that's part of it, that the board has not commented on this, and it's been a vacuum, and maybe that's part of the issue. So maybe saying, listen, here's the guidance. Under these, you need to consider these things, you need to factor these things in, and you need to be sure that subject to the laws and regulations of the state where the patient is located.
I'm sorry, Mr. Glass-Steagall.
And it's not much, but it's
Mr.
helpful, I think.
I'm sorry, Mr. Glass-Steagall was going to...
Dr.
Sorry.
I don't know if it's helpful at this point or if I kind of missed the opportunity to let you guys know how much correspondence and questions we receive at my desk, because I'm the one that all of the emails, all of the phone calls, all of the correspondence about these questions get referred to. And I know Dr. Winkleman, I think on the CPA end, handles most of them, and it is an enormous amount. It's constant, and it's every situation you can imagine, from somebody's in school here, somebody's not, they're a dietitian, there's a special case, they're outside the state of California wanting to provide services with somebody inside the state of California for, temporary practice on that end, to where somebody is licensed in the state of California and is a specialist and wants to provide services to somebody outside the state of California. So and you're absolutely right. It is not stated. And so the answer that I give over and over again is we don't have regulations that speak to that, so long as you're not doing anything against the laws and regulations of the state where the patient is located. So you're absolutely right that we don't speak to that. We speak to temporary practice within the state of California, and then we don't speak to anything about telehealth out with patients outside the state of California. Even our own telehealth regulations speak to telehealth between patients within the state of California.
Right.
So if it's a licensee and I refer them, if it's a licensee of California and I refer them to our telehealth regulations, it's for that purpose.
So maybe we're making it too complicated.
That's exactly.
And what we want to all be able to say is, we all want to be able to say, you must check with the laws. You must be sure you are practicing subject to the laws and regulations of the state where the patient is located, period. A definite statement like that, or is that not right?
We also
No.
clarify that the statute still abides. So if you're a California licensee, you still should be following 2290.5.
Yes.
So yes,
Right.
Yeah.
there is something.
Yeah.
So.
I'm hoping I can make a couple more comments that'll clarify. Dr. Phillips, I absolutely understand what you're saying about not feeling comfortable about endorsing these other situations. I fully understand that. And I understand reluctance to say anything goes along as long as it's okay with the other state. But I don't know then. It may be that we don't want to say anything about that at this point in time. I wanted to mention a couple things. One is this is why SciPact was developed, because I think on many different boards around the country, these same questions have been raised because there's this basic tension between how can a psychologist be practicing in two places? You're practicing where you are and where the patient is. So the California board is protecting patients that are in California, even from people who are licensed in other states. So that's one role, and then the other role being regulating California psychologists, so that if there's a complaint by a patient who's currently in the state or not in the state, but the psychologist is in California, that's another role. So it's like, I think it gets a little confusing with the two different manners in which the board will interact with this interjurisdictional situation. And similarly, I think there's two different aspects to the regulation. One is the interjurisdictional issue of where to practice, which is so complex as evidenced by this discussion. But the other is, well, do we have more to say than 2290.5 or whatever that just says get informed consent? And that's what B and C are looking at.
Yeah.
So I think that there are several issues, that it's extremely complex, and that both aspects are important.
If I could just make a possible recommendation, it sounds like there's some major policy issues that have yet to be resolved on this. I'm wondering if the board would want to consider, because we are in the initial review stages of this, that we could continue along with the preliminary stage, and I'm looking to Ms. Marks procedurally, continue with the package as written. The board, the telepsychology committee reconvene to look at the language with stakeholder input, bring it back to the November meeting, and if we could take another look at the language at the November meeting, could we still do that at the initial review phase of the process?
Well, I think it would be in the initial stage of the process until it's noticed and set for hearing, and even then, I suppose you could say it's still the initial stage. The board could. I don't know how close we are to getting it noticed and set for hearing. I don't know how many days away the November meeting is, but I don't know if you'd want to meet in between, and then at the time of the meeting, if it was set for hearing, at that point you could modify it. And if it's not, then you could approve different language for noticing and set that for hearing.
A quick clarification. Are we that close to having a hearing?
This came up because I was reviewing the initial statement of reasons and the ISR. Oh, but we still have to go through. Never mind.
I'm pretty sure
I was thinking in the olden days. Sorry.
So I so moved with Ms. Sorik's recommendation.
Second.
I'm not sure what your recommendation means. What do you mean move ahead if the telepsych's going to meet or you're going to have a stakeholder meeting and then you're going to bring it back? So.
Because we're still in the early phases of Mr. Glass-Steagall, your arm's going to fall off. Go ahead.
It will. Thank you. My question for Ms. Marks: if this language is approved, how much more review do you think you would need before you gave it back to us with approval to notice it with the department, to submit it to the department with your blessing?
I've already sent the ISR back. I sent the ISR back and gave you this language, but the ISR in this language is based on this language.
Right.
So if the board were to stick with the original language, I think I'd have to do, probably just do a little additional work, but I've given the ISR a pretty good review and sent it back already. But that does not include any of the upward review by either DSA or agencies, and that's what I was sort of forgetting.
And my concern is that if it does get back with approval from Ms. Marks as our legal counsel, and we did submit it to the department, I would. It would be frustrating to see it make its way through really any of the stages with the department with incorrect language and an ISR, and we'd have to pull it from there, replace the documents, and resubmit it all over again with the department. But I don't know, again, how long it's going to remain with you, Ms. Marks.
Full replacement?
We would need clarification on DCA's process at that point if we had additional changes, is what Jason's getting at. Is if it continues on through the longer DCA review process and we do have amendments later on, do we have to start over at ground zero upon those changes, or would it continue on the DCA process?
I'm not sure I know the answer to that. I think it goes up through my office, DCA, then I think agency. And if you were going to move forward with a different package for noticing, you probably, now hopefully the review would be expedited at that time because the reviewing chain would be familiar with it. But I'm not sure, which is why potentially one of the more expedient ways to deal with it is to get it noticed and deal with it at the time of hearing, to amend the language if the board decided to adopt a different policy. Maybe not.
That may be the better route, because then it wouldn't have to go through the initial review phase all over again. Once it gets to the notice of hearing, and then if there's any amended text, even if we had to go out for 45-day notice, it would still be at the second phase. So you wouldn't have to go all the way back through again. I'm just concerned that if we stop, we will have not made progress on this. So I just want to make sure that we are cognizant of the policy concerns that are still unresolved from the conversation today, but that we still, for timing, because things are taking longer, are continuing in a forward momentum.
So maybe not the November meeting, but the next meeting?
That's November.
Board meeting? No, not the November, but the one after that, the February meeting. With that,
Well, I think if we take this approach, it seems to me that we would be able to have a little bit more window of time within which for telepsychology to meet with relevant stakeholders and so on and so forth. I already have 3 committee meetings between now and I think the next board meeting. So I'm reluctant to rush into another board meeting where we've got stakeholders, or another committee meeting where we have stakeholders involved. That's purely selfish. But I think it would give us a little bit more time. We'd be able to solicit more input from people like Dr. Winkleman and Dr. Linder Crow, and could think this thing through more completely. Because I think, in a way, what we as a committee are presenting is our own confusion about how to proceed. To proceed at this point, which is not very helpful to the board members.
I would just like to add a little something. Just that part 2 of A, I think needs some clarification. So, because for a special or limited purpose might be to go to school in California or to attend, some sort of a training program, and ultimately they're going to move back. But people often initiate treatment in California.
Well, that was what the excerpted sentence
Right.
from the preceding section was
Right.
intended to look at. But so we may need to kind of like reshape this wheel, so to speak. But maybe we can get the wheel we do have rolling down the road.
And I think the initial statement of reasons does address the idea of residency and domicile and what that is, and it's.
And I don't want to add to staff, or this is just food for thought, more of a collective. If we look at other healthcare providers in your stakeholder meeting, maybe invite them as part of the conversation, because they have to have the same issues. No, you don't want to.
I don't think that's going to be clarifying in this particular situation, because we do telepsychology so much different than other professions do.
Oh, I just look at it like as a whole, though, from a reimbursement, malpractice. I mean, those are, when I think of telehealth as well, I always think of reimbursements. That's like continuity of care is priority, of course.
That's a whole different.
Correct, but
ballgame.
reimbursements is always top of mind for me
Right.
as well, and making sure that healthcare providers do get reimbursed properly.
That hasn't. That's a whole other issue that we've not had a lot of luck. But I do want to make just one final comment, and that is that if we could just, if we're going to continue to look at it, that is that as far as we know, no other laws around telehealth and no other state addresses the issue of residency. And so we continue to be troubled by this, the reference to being a resident of California. We don't know of any other jurisdictions that use that as a criterion.
And I could add that I often wonder why we have that as part of our proposed language, and I'm forgetting some of the things that Dr. Phillips has brought up, I think.
And I'm less, I honestly, and maybe this sounds like California arrogance, I'm less concerned about what other states are doing, except to the extent that it illuminates it for us. But the fact that they're not doing it this way doesn't necessarily mean I think we're on the wrong path.
But our concern is because of that it may indeed end up being more restrictive than anyone really intends it to be.
Well,
and
all of
maybe,
these things,
and I understand California.
All of these things we can look at in the stakeholders meeting.
California sometimes goes its own way, but it doesn't always work out that well.
So we'll look at that, I would imagine, in the stakeholders meeting as well.
May I say, before we leave this, can we identify those areas that that we want to talk about, come back to the real areas that are a conundrum? Can we identify that before we do whatever we're going to do with this? And I don't mean it in a kind of a lackluster way, but at least because we've done a lot of talking. And so just can we come back and say, for example, residency is an issue. Can we kind of lay those out so that the committee will know exactly what to kind of zero in on?
I think, and I don't mean to give too much credit to Dr. Erickson and myself, I think we have a sense of what people are struggling with and what we ourselves are struggling with.
But can we get...
Can you lay that out for us?
Can you lay it out for... Well, let me just say, can you lay it out for me?
Well, I mean, I
quickly,
think...
No, not to take a...
Okay,
I mean, but just
Well,
quickly. Just one or two words. Based on this. Just based on this. That's
I have
all.
some thoughts that haven't been voiced in this particular way, but I think telehealth has held the promise of more continuity of care. I think as long as the patient is in California, that's possible. But if the patient crosses the state line, I'm not sure that we have the magic of continuity because other laws apply in the state that they live in. So I'm not so sure about continuity of care when the person's no longer in California. We had hoped, I think, our patient, ongoing treatment, they go to Nevada for a while, that certainly we would be able to continue treating them. I don't know that we're going to be able to do that. So that's an
Well,
issue.
that's an issue, whether we're going to approach interstate practice and to what extent we're going to approach interstate practice, where we set the limit line in terms of what we're comfortable talking about. The question of residence and domicile versus originating and yeah, okay, that. Yeah, so that would be one issue that we're going to look at, I think. And whether, I think there's a larger issue, and that is whether we're going to even specify areas in which you can do interstate practice, or if we're just going to give, in effect, guidelines for how you need to do it if you're doing it under your California license.
Okay. I think at the bare minimum, though, we're going to make it clear that you have to be alert to the regulations where the patient is physically located.
And I think that any way you look at this, that's going to be in the regulation. Or where the therapist is located, because you could have a situation where the therapist is out of state for a while and they're talking to a California resident.
So location matters, maybe residency is part of that.
Yeah.
So
So
I
does
need to-
that, does that accurately, do people feel like that accurately represents the issues that we were
I
talking
know
about?
it's clear to me.
Okay.
All right.
Is that clear to everyone? I just was the only.
So
I
it looks to
I
me-
just want to be, because we talked about it. Go ahead.
Do I need to withdraw the
I
motion?
think I'll withdraw my second.
Great.
Yeah.
I've withdrawn my motion.
Okay,
So-
but we need to
So
do
what's
a
the
motion
second?
to move forward with the regulation package.
So
Sadie.
I believe we're here because the board had already approved the language without the deletions. I don't think, without any of the highlighted areas, had already approved that to be noticed and set for hearing. So if you want to stick with the language, which includes anything that's shown as deleted, then you don't need to do anything. If you wanted to change any of it, then you would need to make a different motion.
Clarifying, do you mean that what we see here, and you took out the last part of paragraph A, we do need to vote on that? Yes, if we
don't
like
have
it.
to.
If you want the regulation package to move forward with that deletion, then you'd need to make a motion because the board previously approved the language without the deletion, with all of the highlighted language. So then you would just need to make a motion to approve the language as amended here to move forward. But otherwise, you don't need to do anything. The board had already approved that language first.
I actually
which
think
is
it'd be
how we got
it would
here.
be preferable for us to do it, to make a motion to move forward with the language as amended,
I think so too.
because I think what Ms. Marks has informed us is the ISR, which is a statement of reasons for why we're moving forward with the regulations, is most justifiable when you look at the language with deletions deleted.
I mean, I can go back. I just sent the ISR to the board staff last week, but I can take a look at it and revise it with the original language. My only question was, which is how we got here, is what am I saying that means?
Exactly.
So what I'm saying it means, I suppose, is that we're back to a situation where if services have been initiated here in California, you can continue them interstate.
Okay, so
subject
I
to laws
think
of
if we want our
the other state.
ISR to match the actual language we're proposing, someone should make a motion to move ahead with the amended language and setting it for hearing.
So
Is that
moved.
correct?
I second.
Board discussion? Board discussion?
Yes,
Oh.
here I'm just. I know it's late, but this is the language that we are going to talk about, and will be the amended language that you will use, Noreen, for putting in the IRS. This is the language that you will use after it has been amended.
So this is the language that will be included for the initial review. Once we officially notice for public hearing, we will have had stakeholder meetings and input. And if at that time, at the public hearing, when you guys review the language, we can provide whatever input was provided. And then if you guys need to go out, if it's substantive for 45-day notice, you can do that at that time. But that may cut out like 2 years of the process. If we continue either with this amended language as the motion on the floor is, and start that initial review phase, there's a lot of opportunity still in the future to get the input and make changes later in the process. We're not missing any opportunity to make changes to the language.
And actually, for the most part, it's a 15-day notice for the modified text. It's
I'm
only
saying
40.
if it's substantive.
Well, even if it's substantive, if it's outside what's been noticed, then it's 45 days. But if it's inside what has been said in the notice, then it's 15 days. Okay. Because changes are often substantive. It's just whether or not they're within the what has been noticed. So
I fear that I may lose some of my effort to show good manners here, but I'm trying to move us forward as quickly as I can.
Go ahead, Michael.
Is there any public comment before we vote? Any more board comment? And thank you, Ms. Akwaye Badu. There's always room for asking clarification. I think we're ready for the question.
Okay. Akwaye-Badu?
Yes.
Bernal? Erickson?
Aye.
Fu?
Aye.
Horn?
Aye.
Phillips?
Aye.
Motion passes.
Oh, thank God.
Thank you to staff for helping with all of these recommendations and bringing this to the board for us to consider. It's much appreciated.
We're going to actually probably not spend any time on items number 25 or 26. We will be visiting those at the next board meeting. The one thing I did want to bring to people's attention is that the license card is now available on the Breeze system. I've gotten my own. I paid my $5 and got mine. I went through normal channels. Just to be clear that I did get a preference or priority. So for those licensees that might be listening in and are interested, you can order one of these for $5 through the Breeze system and get rid of that little piece of paper that you've been carrying around that gets more and more dog-eared over the course of 2 years. So I think it's been a wonderful thing that that this was able to be put in place by our licensing department. And
if they order before midnight.
Is it licensing or is it central services? Oh, I'm sorry, central services with the cooperation of licensing. No. Whatever. Thanks. Yeah, there you go. Thank you, Central Services. Shout out Central Services. So we're not going to do items number 25 and 26 beyond that. Item number 27 is a discussion of how board members indicate their interest in being nominated for president or vice president of the board in November 2018. Does legal have anything they want to say in particular as it relates to this, or can I plow ahead?
Why don't you plow ahead and I will burst in when necessary.
Okay. So one of the concerns that's been raised historically is how people can let other board members know that they are interested in being nominated as part of the process. Sometimes people are surprised by the nomination process. It doesn't always play out very smoothly. So at the suggestion of Ms. Jones, we did want to include an agenda item here where people could say if they were interested in being nominated. If you don't say anything now, that doesn't mean you can't still be interested in being nominated. But this is an opportunity to let the rest of the board know that you're interested in being nominated either for the presidency or the vice presidency.
I think that covers it. I think the different boards do it in different ways. Some boards have nominating committees. Some boards have, may have a time where you indicate your intention. I think probably the most common would be maybe someone has suggested to another board member that they're interested, and then at the time of nominations that those people are nominated. Board members are entitled to nominate themselves. And as Dr. Phillips indicated, even if we use the meeting prior to the elections as a time for people to indicate their interest in being nominated, that would not preclude anyone from, at the time when the nominations are being given, from nominating anyone else or from nominating themselves.
Okay. And maybe I'll just break in here and just jump on the bit. I'm interested in being nominated again to be president, but if there's a strong consensus that develops in the board that they want a change in leadership, I'm certainly respectful of that. That's all I have to say on that subject. Are there other people that at this point would like to indicate their interest? They could indicate it at a later point in time in terms of a nomination for president. And we're only self-identifying at this point. It's not a nomination process. Yeah. So are there other, so they're hearing no other voices right now, which doesn't mean we're not going to have multiple nominees for that position. For vice president, are the people that are interested in indicating they're interested in being vice president next year? Okay, well, more will be revealed when we get to that place, I guess. Okay, well, that's item number 27. Are there any recommendations for agenda items for future board meetings? Again, we can't discuss the agenda items if they're proposed, but we can simply take note of them for purposes of future agenda building. Are there any items that board members would like to have included on future agendas? Hearing none, are there any from members of the public? Okay. The next meeting of the Board of Psychology will be on November 16th and 17th in San Diego, California, and we certainly welcome as many people to attend as possible, but also to tune in via our webcast. I would like to just take time, first of all, to thank the members of the public that have participated in our meeting today. It is always very clarifying to hear what the members of the public have to say relative to things. And it did result in some things being resolved today and other questions being further amplified. Oh, excuse me, the 15th and 16th of November. I got those dates wrong. The other thing I wanted to say on behalf of all the board members is how much we appreciate the hard work that staff does in preparing for these meetings. We know it's quite an onerous burden. Not only for specific operating units, but particularly for central services. Don't get used to this, no. But we really do appreciate all the hard work that goes into this, and we don't take it for granted, and we know that part of the reason that these board meetings are as successful as they are in resolving issues is because of all the hard work that's done by staff and management, and very much appreciated. So thank you all very much. And with that in mind, do I hear a motion to
Motion to adjourn.
We don't need a second. I don't think we need a vote either. It's adjourned.